So good morning, everybody, and welcome to the third day of our longevity summit here in Bar-Ilan University. Thank you for the audience here in the auditorium, and of course, many that are joining us on Zoom. So we will start with our first lecture of Professor Vittorio Calabrese from the University of Catania, and this topic will be on hormetic neuronutrition in healthy aging and longevity, from bench to clinics.
Thank you so much to Ilya and all the organizers for giving me the pleasure to be connected with all of you to share my research enthusiasm, which is focusing on neuronutrition in health and disease. I have a pleasure to share with you some information. I'm the editor-in-chief of Open Medicine, a journal which is Q2 in the score, and in the next here will be 3 impact factor. And I invite all of you to send the paper. I will be very happy to consider for publication. I'm in the editorial board of various neuroscience journal, including Aging Research Review, but also current neuropharmacology, free radical biology medicine. And as already I said, my interest is in neuroscience, in health and longevity. Aging, so, is at the frontier of science. And my last books, I have the pleasure to present to all of you. And I know that Ilya got some sample to let you consider for consulting. So the roadmap to longevity medicine is one of my last book, but also brain and mental health in aging, but also explaining health across the science and nutrition, food and diet in aging and longevity. Lastly, human aging, all in this year and a half. This gives a central role to the concept of anti-aging medicine, linking antioxidant with aging and also longevity. My interest in neuronutrition starts from a discovery that I did when I was at New York University in 2004, when we discovered that curcumin can block Alzheimer's pathology, and this had a worldwide resonance just in one day. I was happy, but since then I was motivated to go and deep my interest in neurology and nutrition and biochemistry. This is my background. At the center of my research, there's redox state, oxidant-antioxidant balance, and free radicals are it's central to health and disease. And we know that the low rate of free radical production is necessary for many biological and physiological functions, but when it's too much, then we have the pathogenic determinism for a various degree of pathologies. Neurodegenerative disorders are related to overproduction of free radicals. This is true for Alzheimer, for Parkinson, for multiple sclerosis, for amyotrophic lateral sclerosis, Huntington disease, dementia of AIDS, and aging. But also, free radicals are connected with cancerogenesis. We need one day, a lucky day, to initiate a process which, after 10, 20 years of promotion, results in tumor progression when we have metastasis. So in both cases, we have oxidative stress, a mild chronic inflammation, and from one hand, neurodegenerative disorders, on the other, cancer. That's the basic rationale of chemoprevention approach in cancer, but also the use of nutritional approach to combat neurodegeneration. And central to this paradigm, there's the possibility that with redox modulation of cell stress response, we can not only add year to life, but also life to year, promoting resistance processes, increasing resilience, which is important for cancer, but also for neurodegeneration. And this is the idea of Vita genes that I have developed as all measured Vita genes include sequences in the promoter which are antioxidant responsive element. These Vita genes are gamma glutamyl cystenyl synthase, so connected with glutathione, but also hemoxygenase, NADIAC dehydrogenase, so all phase 2 enzymes, all enzymes which at the gene level they have in the promoter antioxidant responsive element, whereby they respond to diet, to lifestyle like muscle exercise. This is an example of activation of Vita genes. Sulforaphane as a prototypical polyphenols activate a very important transcription factor, which is NRF2, which is free to move in the nucleus, where by binding to sequence consensus are shared by Vita genes promote resilience. These are my publication, including polyphenols in here neurobiology, health and disease, but also we have characterized the role of Boswellia sagra, of frankincense, in a model of brain injury represented by traumatic brain injury, where we have chronic neuroinflammation and where we observed a very potent neuroprotective effect by Boswellia sacra. Central to the mechanism of action of major polyphenols is the concept of hormesis. Hormesis is a biphasic curve where we can see at low dose beneficial effect followed at higher dose by detrimental effect. This is the case of memory-enhancing drugs, which in a low range, they have a memory enhancement effect, but not in the therapeutic range at higher dose. So this is hormesis. Hormesis determines lifespan, but also as a transgenerational effect, implying a central role for food components. Hormesis as a mechanistic approach to understand herbal treatments. We have provided the clue to join Western medicine with traditional Chinese medicine, Eastern medicine. The yin, the yang is rationalized, contextualized in evidence-based medicine by a hormetic approach. Cellular stress response, hormesis paradigm, Vita genes are novel targets for therapeutic intervention, not only in cancer, but in major neurodegenerative disorders. In particular, flavonoids, we have characterized their hormetic profile and dedicate a major attention to the hormetic role of neurogas biology. In this is true for nitric oxide in the central nervous system, but also for carbon monoxide and hydrogen sulfide. A trinigram bioactive gas implying processes leading to brain health and combating brain diseases. This is the reason why recently we have characterized the potential neuroprotective role of mushrooms, Coriolus and Derisium. Why? Because they contain polyphenols. And here we can see how Coriolis is effective at the hippocampus level to increase neuronal arborization, which is associated with cognitive reserve. And with mass spectrometry, we have been the first to show that polyphenols are in mushrooms, and that's why we observe neuroprotection. Nutritional mushroom we have been used in clinical trials where we have developed Meniere disease as a model of neurodegeneration, have provided a rationale for therapeutic intervention in neuroinflammation and anti-neurodegeneration. Here we can see how after Coriolis for 3 months and 6 months, we have a clinical impact of total mood disturbance because subject with Meniere disease, they feel better, they hear better, and they are more neuroprotected. In fact, we have seen that the Coriolis treatment induces at 3 months, even more at 6 months NRF2, but also beta genes such as hemoxygenase 1, heat shock protein 70, gamma-glutamyl cysteine syntase, which is linked to the glutathione synthesis, but also thyroidoxine. In this condition, we have a decreased expression of synuclein and increased expression of BCL2, anti-apoptotic protein. When we have looked at the systemic level, we have characterized, we have observed a systemic oxidative stress as the decreases of glutathione in the plasma of Meniere disease patients shows. From 16, we have 7.2. And after Coriolis, 3 months, even more, 6 months, we have restoration of normal glutathione level. This is a very important data. We have to remember that glutathione is controlled, regulated by gamma-glutamyl cysteine syntase, which has in the promoter antioxidant responsive element being a typical beta gene. And also oxidized glutathione is increased in Meniere disease and decreases after treatment. Looking at mitochondrial bioenergetic in Meniere disease, we have a complex 1 a decrease, like in Parkinson, and the effect of Coriolis. Totally, we have a very important effect, neuroprotective effect at the level of mitochondrial complex activity, which is relevant for the link between mitochondrial dysfunction and neurodegeneration. Using genomic approach, we are one of the first laboratory using lipidomics to characterize pro-inflammatory, anti-inflammatory ratio in the urine of the patients. And we have seen in Meniere disease how Coriolis increases anti-inflammatory mediators and decreases pro-inflammatory cytokines, as we can see for prostaglandin F2 alpha, leukotriene, isoprostan. And this is a very strong results showing that mushrooms can affect redox state and confer neuroprotection. Another aspect of neurohormetic nutrition is linked to the recent evidence that we have provided in my laboratory in Tokyo, where we have characterized the astringent profile of taste receptors. And here we can see how polyphenols, they induce a very significant increase in flow-mediated vasodilation. And just to give you an example of what we can observe at the clinical level, at the level of brain arterioles, we can see here the polyphenol effect at the basal flow-mediated level. This is before treatment. In the brain, it's the same. After polyphenols administration, you can see how consistently increased flux vessel tone we can observe. And this is a tremendous impact in terms of neuroprotection. So last 2 minutes of my pleasure to share my enthusiasm in research with you is dedicated to the innovation of my laboratory, as we are one of the few laboratories that develop mini organs from patients, from volunteers. This is a study conducted in collaboration with my laboratory at Johns Hopkins University, where we have been able to show in autism a very important gene-environment interaction. This has received a very wide resonance, both in America but also in Europe. And that's why we are moving towards a three-dimensional model of a human brain, modeling human brain pathology to develop a new therapeutic strategy. These are my mini brain in my laboratory, and we can develop mini brain from urines, from blood, and this brain is like a power brain for any subject in health and disease. Not only, but we are also able to develop mini here. We are at a very good level of progression. So we are designing new horizon in modeling human brain, mini organs in health and disease. So this is all the results from my laboratory, and the idea is to contribute to human mini organ development. And I want to tell you that this is the real intelligence artificial. Not only artificial intelligence, but we develop with our intelligence something artificial that will integrate in the normal biology, in the normal neurobiology, in the normal physiology. So it's just the reverse that will go consistently with the broad notion of artificial intelligence. But this is even better, is intelligence artificial. Thank you very much.
Thank you very much for this wonderful lecture. I'm going to have mushrooms every day now for lunch. Is there any questions from the audience?
I hope to come to Tel Aviv soon with my heart. I want to tell you one thing, that in my life, always I have been helped by Jewish, in America especially. My life has been really influenced. I love your culture, your heart, and you consider me as a very good friend. Shalom.
Thank you very much.
Thank you very much.
Okay. So in the meantime, hi everyone. My name is Shai Shen-Orr. I'm with Tzipi. I'm co-organizing this session. I'm from the Technion. And so the next talk is by Professor Evelyne Bischof, who's the medical director of Sheba Longevity Center, and Professor Tzipi Strauss, who's the head of the Sheba Longevity Center. And the title is Healthy Longevity Medicine, Optimizing the Biological Age of the Individual Performance in a Clinical Experience. Take it away.
Perfect. Okay, great. So first of all, thank you so much to the organizers and especially to Ilya for having me. And I apologize that I cannot be there in person. And it's really a great pleasure and honor to be a part of the conference for the second time. It's a great success, and I learn a lot. And I would just jump into the first part of the presentation, which, as you mentioned, I will share with Professor Strauss. And we are so happy to do that and really to share the concept of clinical longevity medicine and also practical pathways and practical processes which have been done and are still being developed in the Sheba Longevity Center in Tel Aviv. So without further ado, I will just start very briefly on reminding about the definitions on longevity medicine, and this will give a gate opener to the further presentation. So in early 2020s, longevity medicine for the first time was mentioned in a publication that was actually trying to focus on saying what is longevity medicine, and in that definition, it was also capturing what is it using in order to guide patients and be in the clinic. So at that point of time, we said longevity medicine is a branch of precision medicine. It is specifically focusing on AI, empowered health span and lifespan. So at this point of time already it said both health span and lifespan are in the focus. This definition has evolved, and hopefully a paper will come out soon in the same journal from the Healthy Longevity Medicine Society, which convened in 2022 and said, right, we have to shift from longevity medicine to healthy longevity medicine for the purpose of saying that we are really focusing on health span. We didn't want to call it health span medicine because it's still longevity medicine, but it's all about optimizing health span, focusing on optimal ranges, developing ranges that are optimal for an individual and then also for cohorts, and doing that by targeting age-related processes, meaning using the great discoveries in neuroscience that we have, and also the AI and computational science to really also model it into trajectories, and to do that along the lifespan. What is probably missing and is coming into it is that it also has to be longitudinal with the flexibility to adjust as the lifespan progresses. And secondly, also in terms of the thresholds of the lifespan and health span, which I will refer to just in a moment. So that's us, that's the Healthy Longevity Medicine Society. And some of the points that are encaptured in the mission and vision of the society are hopefully helpful and crucial for the field. Some of them, such as setting up publicly funded hospitals and centers of longevity. That is something that Professor Strauss will go into the great detail, because we have an actual example how it is already done and existing and now just developing. But some of the things that the society is doing is also creating guidelines and standards and recommendations. And hopefully also very soon we can show it to the public that just now one of the governments in the world has implemented into their policies actual standards and golden standards of longevity medicine for the accreditation of longevity clinics, for the accreditation of physicians, and also for the public support of longevity medicine efforts in a country. So I think those very, very strong, powerful steps and movements are really game changers, moving from only the bench or also moving only from the private sector, which is of course very important, necessary, absolutely, we collaborate closely, but it's also very important to be in a setting that is public, academic, and yet clinical. So we have those three places that right now are existing, or each of them is running in a different place, but also this will be shown by Professor Strauss in a great detail what exactly those three centers are doing, but we are collaborating with Mayo Clinic, with the Alexandra Hospital in the US, and with our center at Shiba to really have the exchange, the real platform that we need as doctors to discuss our patients, to discuss our protocols, to discuss the processes and the upcoming results. But all of this is only possible if we also implement AI into that game. And that is something that, of course, in the clinical academic setting is still very, very immature and preliminary, yet it is existing. And those steps are also very important in order to shift the paradigm and to actually have a data lake of all those clinical data, to also have a platform that is integrated with the EHR, so that as we are collecting the data longitudinally in longevity medicine of the cohort of so-called healthy patients and diagnosing them with the longevity diagnostics to finally also identify the right biomarkers of aging, we need to have this platform in order then to integrate also the data from the sick care. And only this way we can have this reciprocal, mutual beneficiation of both sides. Why do we do that? We always say we want to close the health span and lifespan gap. We know this one is very difficult, expensive, and burdensome, and that's one of the goals. However, what we are often missing is that we do not only want to close the horizontal kind of a path of health span and lifespan, there is a gap, and those years are burdensome. But we also need to understand that the health span threshold will be different for different patients. And when we say we want to have longevity medicine for all, we do not only focus on having it on specific populations, specific ethnicities, specific sex and genders, but also in healthy and unhealthy patients. So yet another thing we are dealing now also in the society, in the working group, is to identify who is a longevity medicine population. And after, of course, it's only recommendation, expert-based recommendation, nevertheless, we came up with the point that, in fact, pretty much almost everybody, besides a very terminal palliative patients, are actually included in that setting, including, of course, pediatric patients, and of course, even almost like we call it the preconception longevity approach. So this type of a threshold will be different. So very clearly, a health span goal of a cancer patient, cancer survivor, it will be very different than a person who is athletic and is very young and did not have any comorbidity yet in his or her life. But this type of factor that will also be changing along the lifespan needs to be calculated into the algorithm. And that's pretty much only possible already with large language models and newly also with quantum, because without that, we cannot really then also go from this large modeling to a granular question, such as which protein will be the best for a specific target. But when we take a step aside, we still need to go to the basics, because without good basics, we cannot do nothing. So setting up diagnostic and monitoring processes that, of course, will have some sort of flexibility in each of the centers is very, very important. That's one of the publications which we have published, and Professor Strauss will explain it a bit more. But another thing that we want to take from those type of protocols, to take from this side of senior doctors practicing in a department, is really to give further. So our experience also in our center was, without junior doctors, we can't move forward, we can't grow, we can't do nothing. And so we were very blessed that we have really tremendous talent in our center, from senior to junior doctors. But some of the things that were also done on top of that, right, on the educational part, is Longevity Education Hub, which you might know, and some of the academic centers are very close friends also of the Longevity Nation, including ILIA. And this is the only CME accredited course that was also already implemented in the NHS system already 3 years ago. But how it developed now, it developed to a course that is globally spread and trained over 10,000 physicians. National chapters have been built. Some countries really prefer to learn in their own language, and it was not so easy. And finally, the big achievement was that the longevity medicine course curriculum is integrated already in the university in Indonesia in the core medical curriculum, which might sound as something small, but it's actually quite big. So imagine you're a doctor, or imagine yourself as a doctor. If we have doctors in the audience, you actually study, and within your courses of cardiology, oncology, endocrinology, forensic medicine, pathology, you have a part that is dedicated to longevity medicine, not a trivial part, actually several hours. So altogether 480 hours spread over 6 years. That's pretty amazing. And that is spreading. And of course, it was a lot of work, 2 years of very heavy work, to adjust such kind of curriculum, but it's done. And also, this type of education is now being brought to the doctors in their internship and residency. So doctors who have finished their medical school but are now training clinically. And Lithuanian University of Health and Science is the first one that is actually implementing it for family physicians, which at the end of the day have biggest and the closest contact with their patients. So those developments are happening, and we should not forget that, of course, it's very important to train the doctors across the entire path of the doctors, but also people who are involved at large in such a center, which of course spread towards therapists, psychologists, nutritionists, physiotherapists, of course, people who are involved in research, which is so super, super important. And of course, all the other people who are involved as healthcare professionals, so also neuropsychologists and nurses and so on. So those are some of the things that we are doing, and it's very important because people in an academic setting, if they work in a hospital where they clearly every day also have the ability to talk to people who see sick patients, them themselves partially also sometimes work in the sick care setting. We all have one of our legs or our fingers still in the sick care setting. And it's very important for us because the reactive medicine is important and is there to stay. We have to react to the disease and treat it. But it's also very important to have knowledge what's actually going on in prevention. Preventative task forces are growing and developing. And yet to see the importance of longevity diagnostic being integrated into all this and then interventions based on that. And only through that, actually being within a center that is academic, talking to people, working with people, leaders of the department, it was possible to really exchange the idea of what longevity medicine is and is not, and then to work together and to learn from the sick care and implement the longevity path so that we don't only bring the patient from their biological age that they are at now compared to their chronological age with interventions towards optimized biological age and optimally always keeping them at the so-called IPP, the individual peak performance level, using all the data of longevity diagnostics that we have, and of course, generative AI, deep neural network, and now also other large language models that we can have in order to have the trajectories. Simply said, what is the biological age? What's the optimal biological age? What are the oscillations within the day, within the month? And ultimately, what is the pace of aging? Because it's great to have trends, but it's much more important to have the pace right there. And that's why we are doing diagnostics and interventions. And this is very important to identify biomarkers of human aging. No restoration of biological age can happen without those. And also, we cannot move forward the needle without having the biomarkers. And you know probably that we have two very large biomarkers of aging consortia, one huge one in China for Asia and one at Harvard. And what colleagues are doing there is so amazing and very, very great publications, which I recommend you to read. But what is very needed is the clinical validation of those in cohorts that are outside of only controlled randomized clinical trials, but also the real world population that is coming to the clinic. And secondly, also to bring it to the public health, why don't we have a screening of biological age, for example, at some point of time, just aside of mammography or PSA measurement? And some of the biomarkers have been already established very long time ago, usually in clusters, by systems, by organs, by cellular functions, by some of the functions of the body, such as memory, performance, and so on. And those panels are actually not new, as I mentioned. Some of those have been proposed a while ago. However, it was always very difficult and challenging to aggregate them and to easily find them, and to move away from using only one linear or only selected two-dimensional markers. And that is now finally possible with AI. So right now, we can really use those clusters and go very, very deeply into those that are validated for diseases, those that are not validated at all, and to cluster them together. And so, for example, Biomarker of Aging Consortium made it also very, very clear that those markers that have been established before are a part of that, and that we have to integrate more markers. And those more additional markers are mostly digital. So all of our wearables, continuous measurements, and so on, those probably will have a role just aside, like same level, side by side to laboratory testing or omics. And interestingly, or very importantly, diseases and aging, of course, they go hand in hand. And some of the biomarkers of aging have been proposed based on different diseases, mostly cancer, simply because cancer has the most paralleled pathways. So tumorigenesis and aging have they share a lot of pathways, and also because we know that there is this point. We know that there is this one destabilizing event on the trajectory of a patient that can bring a patient from being apparently healthy to frail. And this destabilizing event in oncology is very clear. Very often it's chemotherapy or radiotherapy. And to know when is exactly this point of being easily turned with an event towards frailty is very important to make decisions, for example, in terms of therapies. Again, cancer patients are just one example, but very important example, because as we age, we will have more and more cancer patients. And as we try to prolong life, we will also see more and more cancer. So those are those few things that have been established. And breast cancer was also one of a very good examples where methylation played a good role. But again, that's not enough. And so I will skip this part to go to Professor Strauss. What do we want to do with that? The thing that we want to do with all those biomarkers and sifting through them and validating them is to actually then be able to say which of the interventions are or are not helpful, and when and for whom. Thank you. With that, I will close.
Thank you very much, Eva. You take all my time. Okay. So thank you very much. And I will continue from here. So Eva is my medical director in Sheba Longevity Center. And if we try to conclude what Eva said about all the biomarkers and all the importance of having bench to clinic, so we actually established the first healthy longevity department in an academic hospital. And we have 3 arms for our center. We mainly focus in a longevity clinic, but we have also an important arm of longevity research and longevity innovation. So we actually, the main focus for us is our 4A. We wanted it to be accessible, the longevity, so it is in a public hospital. It's affordable, which means everybody can do longevity, not only in private clinic and not only in laboratories, but it's completely free for the first part that we are doing it. It's, of course, academic, so every test that we are doing, every intervention are all valid and evidence-based medicine. And as Eva mentioned before, AI is extremely important in longevity, and of course, it is incorporated in our clinic. So I'm the head of the Sheba Longevity Center. We have Dr. Abigail Goshen, she's the head of research, and of course Eva, she's our medical director. And we have our medical board, which is, as you probably know, of course, all the people here from Stanford, Tom Randu and Brian Kennedy and Professor Neil Bardsley, James Kirkland from Mayo, and of course Alex, which is in AI, and Professor Grossman, who is was the dean of medical faculty the last 8 years, and he was with us from actually from day one. So what are we focusing on in our clinic? So we started, as I mentioned, in a study that we are having 1,500 patients, or participants, they are not patients, with a SHARP study. This is the Sheba Healthspan Research Population Trial. Patients are coming, the inclusion criteria is whether you are above 50 years old with no neurodegenerative disease or cancer treatment in the last 2 years. Then you can enter the study. You have several questionnaires before you come, and then you come for a full day of assessment, which I'll elaborate in a minute. It's a 7-hour assessment. After this day, at the end of each week, we are doing randomization. The computer is doing randomization, having a study group and a control group. 80% will go to the study group, 20% control group. The study group, the 80%, will come back after 2-3 weeks for a summary. They get all the results and intervention, what to do, how to improve, and an application. The 20%, the control group, do not get the result. Then both groups come back after 6 months for blood check and some questionnaire and body composition test. And after 1 year, both groups come for a full day again of assessment. And then, the control group, we're doing crossover, the control group will then get the intervention. So they will get it a year after and another year after. So they kind of like having 3 times instead of 2 times. We want to incentivize the people to come back because they are controlled. So what we want to see is whether there is a difference and there is improvement in the study group compared to the control group in all our measurement, biological age, and now we'll show you what we are testing. So we are starting this day. It's a full day, as I mentioned, 7 hours day. So we start with blood check, and we mainly also focus on a lot of biological age. So we are doing a metallurgical age, epigenetic methylation clock, and we try to and telomeres, and we are trying to develop other biological clocks such as cardiac, microbiome, photo age, NLP, physio, and clinical. And now I'll show you just a short movie. This is actually in our clinic, already having a patient from March. So you enter our clinic and you see it's a beautiful new area. You feel like you are very healthy there. You start with the 10 station. So first blood check is a full panel with hormone, biobank, different vitamins. It's metabolomics and proteomic. Cognitive station, so we're doing MOCA, Neurotrax, and Delphi, which is a new EEG stimulation and can predict Parkinson and Alzheimer. We're doing a lot of sensory, so vision, hearing, we record voice, we're having smell check and oral hygiene. Then we have cardiovascular, so we do respiratory tests, we're doing fast echo and ABI and PVW. And DEXA, body composition, together with a physiotherapy that is doing a lot of tests, equilibrium, balance. All the patients are giving microbiome. Women are going into gynecology for menopause, and men are questionnaires for andropause. And all of the patients are going home with a sleep assessment and sleep questionnaire. So, okay. So after this day, as I mentioned, the study group come back and then they get the results. We develop a specific patient dashboard, which is connected to the Chameleon, to the EMR. And in order that the patient will understand, because we are doing like 450 different results, it's a lot. So we kind of did it into a domains similar to what the patient is going through. So stamina, cardiovascular, sleep, and then it gets an algorithm that gives it a score between 1 to 100. So for example, this patient got the biological is 56, his stamina is 37, and it went down because of grip strength or 6-minute walk or low muscle mass. Then this patient get intervention. So it's very personalized, of course, according to the what we saw in his course. And we develop a special app. This app tracks your steps, tracks your stamina, your sleeps, gives you questions. We monitor it, and we also see how the patient is doing. We call them, we see how many hours the patient slept, or did his intervention, or take his vitamins, etc. And we keep on tracking the participant every week, talk to them, and try to understand because the most important is motivation. If we want people to have results, we need them to do. It's a proactive medicine, longevity, right? So we need them to do the intervention that we actually told them to do. So just I want to show you some preliminary results. We already have 400 patients. As you can see here, the average age is 61. We have a little bit more women. 70% are married, 57 never smoke, BMI 26, for 61 is not bad. Regular physical activity, we can see it's 70%. I have to say it's high. Okay, if you ask general population who is doing 2 times a week physical activity, is around 30%. So you could see people that come to a longevity center from the beginning, they're a little bit more active. Insomnia, or borderline insomnia, is around 28%, which is it's kind of like in the what is known in the population. Hearing screening impaired, 40%. What was interesting is the MOCA score, which was a little bit low. MOCA is the cognitive test, which is 26 and above is normal. It was a little bit lower. And that was an interesting thing that we saw. And hematological age, you see that the patients were 3 years approximately younger in their biological age than their age. So good candidate, but it's on only 400. I hope, I don't know what will be in the next 1,000. So as mentioned by Eva before, we're doing a lot of collaboration. We have with the Mayo Clinic and Singapore. We also published a paper which we are trying to have protocols and to how to establish healthy longevity in a public hospital. We have academic collaboration with Tel Aviv University, Weizmann Institute, Ariel University, and Reichman University. Industry collaboration with Quantalas. This is the machine that I told you, the Delphi. It's an EEG with a magnetic impulse. ASAP is actually an echo. This is a Shiba startup, which is doing a fast echo, 4 minutes, and then you get the ejection fraction, and the biological cardiac age. And effective, it's application for cognitive games, which we are also doing a collaboration and test with them. This is our website. You can see here, longevityshiba.coil. We have all what we are doing. We have 17, on top of SHARP study, we have other 17 research that are going on. And of course, we are happy to collaborate. I don't have it here, but we have our next conference. The second conference of Shiba Longevity will be in May 7 and 8. So you're, of course, all welcome. Thank you very much. Is there any questions from the audience? From the Zoom? Someone? Yeah. Wait, if we want...
very nice talk. How do you assess hematological age?
So we send it, it's a 45 markers, blood markers, and we send it to Deep Longevity. So we're sending outsource and they bring it back to us. So they have no idea who is the patient, what is the age. We send anonymously 45 blood markers and they give us back the blood age. 45, it's they are known. The 45 markers for hematological age usually are very steady. It's hemoglobin, hemoglobin A1C, blood, CBC, iron, alpha fetoprotein, a lot of... it is very common and the one that is already used everywhere. Okay, so our next talk is Professor Anzhela Kozhokaru from Bronzine Federal Medicine Biophysical, Sleep and Longevity, and the talk will be about, biophysical sleep and longevity.
Good morning, dear colleagues. Firstly, I would like to thank the organizer of the conference, Elias Chamber, for the opportunity to take part in this conference. The topic of my today's report is sleep and longevity. This topic is quite extensive, but my report will briefly focus on the following issues: key modulators, sleep homeostasis, oxidative stress, changes in sleep architecture and patterns in the elderly, factors influencing the regularity and duration on sleep in elderly, sleep and cognitive reserve, intermittent hypoxia, a role of cognitive disturbances, cardiovascular diseases and metabolic syndrome, hormetic nutrition and sleep relevance to sleep disorders, health, longevity, life, and approach to maintain healthy sleep in advanced age. On this slide presents a model of homeostasis. The concept of homeostasis is being increasingly appreciated in all situations involving everyday life. On one hand, when exposed to small doses of stress factors, there is an increase in the transcription factors. They activate vitagens and hemoxidinate heat shock protein 17, thyrodoxine, citrulline-1, gamma glutamate cysteine synthetase, and which contribute to longevity. On the other hand, when exposed to high excessive doses of stress factors, oxidative stress is triggered under the influence of exogenous and endogenous factors with the release free radicals, reactive oxygen species, and reactive nitrogen species with detrimental consequences for physiology and health, leading to various diseases. Everyone knows the phrase by Friedrich Nietzsche, "What doesn't kill me makes me stronger." In this article, Martin Hucker with colleagues consider the hypothesis deprivation of sleep could benefit humans. Using the Homesis model as an example, in somnology, the main stress factor can be deprivation or lack of sleep. That is a single sleep deprivation, as the authors believe can lead to positive result. But it has long been known, and there are many experimental and clinical studies that long-term deprivation leads to various adverse health effects. This model shows that various dimensions of sleep-wake function can affect distal outcomes on health and function. Intermediate processes may include epigenetic, molecular, and cellular processes that in turn affect system-level processes. This model also recognizes that the relationships between sleep-awake functions and molecular and cellular systems and organism-level outcomes are reciprocal, just as sleep affects function and health, so function and health influence sleep-wake function. The sleep-wake cycle is controlled and balanced by two internal processes. The circadian rhythm at the homeostatic drive, whose activity decreases with age. This picture shows the related change in the sleep architecture in the elderly. With age, a decrease in the following sleep parameters is more often observed. Percent slow wave sleep, percent rapid eye movement sleep, and an increased sleep latency and wake after sleep. This slide presents factors affecting the regularity and duration of sleep, which include the first group, directly sleep disorders, represents the current classification and main group of sleep disorders, third edition. The second group present various comorbid disturbances, and the third group present environmental conditions. The importance of sleep regularity and duration is actively debated in the literature. This slide presents the late prospective cohort study. Sleep regularity is a strict predictor of risk of death more than sleep duration. The authors used objective sleep measures from a large cohort, more 60,000 patients, and 10 million actigraphies were performed. The authors also found that people with irregular sleep patterns had a higher risk of mortality, and that sleep regularity was stronger predictor of mortality risk than sleep duration. Regular sleep may improve health and survival. Another later study examined the association of accelerometry measures sleep duration with incident cardiovascular disease and cardiovascular mortality. More than 19,000 patients were examined. A total more 13,000 participants developed cardiovascular diseases, and more than 1,000 participants died of cardiovascular diseases. Compared with sleep duration, 7 to 9 hours per day, the accelerometry measured sleep duration less than 7 hours per day, associated with higher risk of incidence cardiovascular disorders related mortality. In a recent study, the epidemiology of sleep disorders in Israel, the authors examined nearly 200,000 people. Prevalence of sleep disorders increased with age. 5.2% in young adult and 22.3% among seniors aged 75 and older. The most two prevalent disorders were insomnia, about 7%, and sleep-related breathing disorders, 2%. The authors concluded the overall prevalence of sleep disorders included insomnia and sleep-related breathing disorders in Israel were similar to other Western countries despite stressful life events of ongoing war and terrorism. On the relationship between sleep disorders and their impact of cognitive function is being studied actively. This figure demonstrates the results of recent review in which the authors summarize existing research examining interaction between the role of cognitive reserve, sleep alteration, and cognitive function. The gray arrow suggests a lack of research investigating the role of cognitive reserve and protective or enhancing factor on sleep. The green arrow represents the promotion effects of sleep on cognitive reserve, as well as the protective and ameliorative moderating effect of cognitive reserve on the relationship between sleep alteration and cognitive function. The red arrow shows the terminal effects of sleep alteration or cognitive function. This slide demonstrates the impact of obstructive sleep apnea. This slide presents a possible model or relationship between sleep disorders, breathing disorders during sleep and during function in the elderly, as well as a potential mechanism of disorders occurring during intermittent hypoxia that have a negative impact to cognitive function. Intermittent hypoxia leads to sleep disorders causing insomnia and severe sleep and cognitive dysfunction as consequences lead to various negative physiological and social effects. This slide demonstrates the impact of obstructive sleep apnea upon vascular regulation depending on its severity. This issue is being actively studied in experimental models and clinical studies. With increasing age, the severity of apnea-hypopnea syndrome increases, which thereby increases the number of cardiovascular disorders. This slide shows a model of potential mechanism linking sleep apnea and diseases of carbohydrate metabolism. Intermittent hypoxia in sleep apnea triggers hypothalamic pituitary adrenal axis dysfunction with all further reactions. Sleep fragmentation and restriction increases systemic markers of inflammation as well, followed by a cascade of biological reaction. All these leads to insulin resistance and impairment, glucose tolerance, and development type 2 diabetes. I would like to note that there are many clinical studies indicating that the administration of continuous positive air pressure in apnea-hypopnea syndrome significantly reduces the severity of the syndrome apnea-hypopnea in patients with cardiovascular diseases and carbohydrate metabolism disorders. In recent years, the use role of polyphenols such as resveratrol, rosmarinic acid, chlorogenic acid, catechin, sulforaphane, curcumin, and other has been actively studied in various diseases. There are also studies examining the effect in polyphenols for improving sleep and sleep disorders. According to the available data, it can be noted that polyphenols might be efficacious adjuvant therapy for decreased odds on sleep disorders. The beneficial effect of polyphenols also depend on the treatment duration, and further experimental and clinical study are needed to study polyphenols on sleep and explain their mechanism on action and improving sleep. When studying the protective role of neurotrophic growth factor on cognitive impairment in conditions in chronic intermittent hypoxia and sleep fragmentation in mice, it was found that sulforaphane nuclear factor erythroid agonist elevates cognitive impairment induced by chronic intermittent hypoxia and sleep fragmentation by modulation and endoplasmic reticulum stress. This slide shows the results of research study that showed the protective effect of resveratrol in chronic intermittent hypoxia lasting for 6 weeks. The authors found that resveratrol ameliorates intermittent hypoxia-induced spatial memory deficit in young rats. Resveratrol attenuates intermittent hypoxia-induced expression of P47 FOX subunit of nicotinamide adenine nucleotide phosphatase oxidase. Therapeutic role of dietary polyphenols as essential regulation contribute to development of new therapeutic strategies capable of suppressing oxidative stress, neuroinflammation, intermittent hypoxia, and beneficial effects on cognitive function, metabolic syndrome, and cardiovascular diseases. Existing relationship of sleep with a different disease, metabolic, cardiovascular, and other diseases, ensuring healthy sleep and improving the quality of life during aging is an important issue, since age-related pathologies have a significantly increasingly impact of health system. Poor sleep and sleep disorders shouldn't be considered an inventable part of aging process. Back in 1990s, a model of healthy sleep in advanced age was proposed. This model is useful for regulation of sleep in elderly and focuses on the processes of adaptation and successful age, and also consists 3 key behavioral components: selection, optimization, and compensatory strategies. Can lead to a reduction in different disorders and may promote longevity. And conclusion, the role of sleep in achieving longevity can't be overestimated. Early diagnosis and treatment of sleep disorders and respiratory sleep disturbance, quality sleep, can lead to a reduction cardiovascular disorders and may promote longevity. Sleep, of course, isn't an isolated factor in promotion of long and healthy life, but rather it is an essential element of balanced lifestyle, what depends on different factors: quantity and quality of sleep, cognitive and behavioral function, nutrition support, physical activity, various comorbidity diseases, social interaction. I would like to end my report with a phrase: sleeping enough is our way to better health and longevity. And I'd like to finish my presentation saying thank you, Professor Calabrese, Vittorio Calabrese, University Catania, for helpful suggestion. Thank you very much for attention.
Thank you very much. I think sleep is extremely important. Just want to mention that in the cardiovascular preventive, that they say 150 minutes of activity and Mediterranean food and all of that, they just 2 years ago added 7 hours sleep to prevent for cardiovascular. So sleep is extremely important, and I really love your talk.
Alrighty, and now for something completely different. It's a pleasure to introduce our session. So our moderator is Dr. Jen Bardsley from the British Council, Dr. Rachel Hines from the Portland Hospital, and Dr. Vilma Sarado from MIA Portugal. And the topic is the impact of menopause on aging and well-being. So, pleasure.
Hi, everyone, and good morning, Rachel and Vilma. So I'm excited to help moderate this very interesting and special session for this. We are going to be discussing menopause and its influence on healthy aging. We know menopause has existed since the beginning of human history, but it's only recently become quite a hot topic and a specialized field in its own right in both medicine and science. So this morning we're going to explore with two special guests. We've got Dr. Rachel Hines, a GP specializing in women's health and the menopause, and Vilma Oliveira, a senior researcher in menopause and aging. And we'll try to get through some of the key research areas and how specialization, both in practice and science, can improve societal health and longevity for individuals. So I don't want to linger because I know we have a lot to talk about in a relatively short span of time. So if I could go to my guests for some quick self-introductions, and I'll start with you, Rachel, just because you're the first on my screen. If you could go through and introduce yourself, your background and your experience.
Thank you for inviting me today. I'm a general practitioner, so a GP, and I've always focused on women's health. So I've got diplomas in obstetrics and gynecology and sexual and reproductive health care. When I was working in community gynecology for a few years alongside my GP job and developed a real interest in menopause, and then completed my advanced menopause training. So I'm now a British Menopause Society menopause specialist, and I work in an obstetrics and gynecology practice where I work as a menopause specialist and sort of provide holistic care for menopause. I'm sort of particularly interested in premenstrual syndrome and migraines around menopause, but see women with all aspects of menopause care, and also focus on contraception and women's health as well. And I've got lots of experience working in digital health in menopause as well, so working on a wider scale of bringing menopause to everyone, hopefully.
Thank you so much. And Vilma, can we come over to you for a quick introduction?
Yes, sure. Thank you. Good morning, everyone. And thank you for the invitation to be here. It's my pleasure to talk about this subject that I really love to do my research on. My name is Vilma, and I'm a senior researcher in the field of aging. I had a degree in biochemistry since 2002 and a PhD in cell biology. I work at assistant investigator at Multidisciplinary Institute of Aging. And my research explores how estrogens, the female hormone, regulate the cellular metabolism, and how the hormonal shift during a menopause can lead to menopause-related health conditions. You are muted.
Now I'm on mute. Sorry, it's a little early here in the UK. Yeah. So I'll go to you, Rachel, first with an early question. Menopause has become an evolving specialty, and maybe you could talk us through what factors have contributed to its increased focus, and how do you see that increased attention influencing healthier aging in society?
So I think it's been such an interesting time. We've got more and more women in the workplace, and women are living for longer. And so now 50% of women will live their life in a postmenopausal state. By 2025, more than 1 billion women will be peri or postmenopausal worldwide, which is obviously a huge number. And the average age of menopause worldwide is 48.8, which is quite specific, but it reflects how much of our time is still spent in a very productive way, which is a change to previous. The average age for death in the UK is 82.8. Obviously, it does vary worldwide, but it's a huge amount of time. And I think for many years, following the Women's Health Initiative study in 2002, prior to that, menopause hormone therapy, or HRT, was prescribed, and the findings of that initially scared women significantly, and the focus really shifted away from menopause. I think it was thought it was going to give you breast cancer, it would give you heart disease, and the focus from menopause just dropped. And as a GP, women weren't presenting with menopausal symptoms. It just didn't become, women weren't seeking help that they needed. And then in the last few years, or certainly in the UK, the NICE guidelines came out in 2015, and increasing evidence showing actually that HRT is safe to take for many women, not everyone, but most. And I think it's really shifted the focus on how we can manage menopause. And in the last few years, certainly in the UK, that it's become so present in the media, so sort of celebrities and influencers, journalists, there have been documentaries, but it's really brought it to the forefront of attention, and therefore it's really changed, I think, how menopause is seen in a positive light, and it's not something that's embarrassing to talk about. And certainly as a GP, the change was profound, from prescribing HRT occasionally to it being half my clinic. So it's been a really big shift when I was doing that. And I think the increased attention is really positive. Women are presenting saying, I'm having these symptoms, what can I do about it? And in terms, therefore, it's leading them to kind of implement lifestyle changes, prioritize their health. And that links into having healthier aging so they can get advice, make, exercise, dietary changes, everything, which will then lead to healthier aging. So it's a hugely important and, from my perspective, really exciting time, because it really does feel that change is going to happen and is happening already.
Brilliant, thank you. And Vilma, as a senior researcher in the field of aging, could you shed some light on some of the latest research regarding menopause and how it affects women's healthy aging? And how does our research in this area help bridge our gaps in understanding on the long-term impact for women's overall health?
After menopause, there is a shift in the hormones in women change, and that affects all women health, not just, we don't get just the symptoms, the normal symptoms that most of the women talk about, like hot flushes and all of those migraines and all of those symptoms, but it also really affects the health of the body. For example, there is an increase the bone resorption, so an increase in osteoporosis, a risk for your osteoporosis and bone fractures. It's also interesting that women after menopause, they are more sensitive to heart problems and heart attacks too. So now, it's not easy to work with hormones doing basic research that I'm doing, because in human body, we have a mixture of the hormones changing and different concentration of the hormones. But so we try to, for example, explore the effect of the estrogen in certain organs and certain cells, and explore those kind of the mechanisms to understand how the cells behave in the presence and absence of the estrogen, and doing different hormones, and play a little bit with different concentration of those hormones, try to find in vitro the mechanism that we can find a way that, okay, this mechanism could be addressed, and maybe in vivo we could improve the symptoms. So further in vitro studies, we also do animal studies using, for example, rats, where we do over-optimization and try to understand a little bit more how the system works in the absence of those hormones. So this is how basic research helps clinical research, understanding the mechanisms where those hormones are involved and how the cells function. So.
Brilliant, thank you so much. And I know there's been a mention of hormone therapy already, so I'd like to get a little bit into the recent release of the International Menopause Society's 2024 white paper on menopause hormone therapy, and that we know that there's some benefits. We know there's some controversies around it, guidelines for prescribing, and anything that might be an alternative option for people. So Rachel, I'll come back to you about the white paper and its 5 W's of prescribing.
Yeah.
Who is it for, what it is, when, why, and where it can be accessed. Could you elaborate on that and the significance for your clinical practice?
Yeah, absolutely. So the International Menopause Society released that they would do a white paper every year for World Menopause Awareness Month. And so their white paper recently was to provide a position statement about menopause and menopause hormone therapy, and to address the key controversies around this. And the purpose of it was to provide a blueprint, and it's to base future ethical management of menopause. And it's from a clinician point of view, it's really helpful. And they also have there's leaflets for women that can read as well, so it's more helpful generally. But essentially, in terms of looking at who can take menopause hormone therapy, their definition of this is women with natural and surgical menopause who are experiencing distressing vasomotor, so hot flushes and night sweats, and or vulvovaginal symptoms. Essentially, it's women who are experiencing symptoms that are distressing. So any of the symptoms you can experience and that are impacting their everyday life, their quality of life. There's discussion within it. So should high-risk women be prescribed? And it focuses on categories of women who really should take menopause hormone therapy. So women who have premature ovarian insufficiency, so menopause under the age of 40, and menopause aged 40 to 45, so early menopause. These women should be, if they are able to, should take menopause hormone therapy because they're at higher risk of cardiovascular disease, hypertension, cognitive decline, osteoporosis. So we do strongly encourage these women to take the menopause hormone therapy. So that's who. In terms of what, it's looking at what types and doses. So menopause hormone therapy is, you need estrogen to treat your symptoms. We have symptoms because of fluctuating or falling levels. And the sort of what types and doses is looking at what's suitable for each individual. So it's looking at what you need to think about, what the patient preference is, if they have a uterus, what contraceptive needs they have, what their symptoms are, and the severity of them, and also what comorbidities they have as well. For example, if you have migraines or clots. The dose you need is usually low, but we treat it appropriately. And you need to decide whether women will have it transdermally, so having it through the skin, or having it orally. If you take it orally, there is a small risk of blood clot on the leg and on the chest, and also a small increased risk of stroke. So it's balancing the most appropriate type against their history. So there are different types of estrogen. There are also different types of progesterone, and we're increasingly using body identical hormones, so the same structure as your natural hormones, as it's thought to be lower risk. I'm sure there's lots more information about that. We also use testosterone for treating low libido. So there are looking at what the types of hormones are, when it should be started and stopped. So we should start it if the symptoms are interfering with daily life. And again, with premature ovarian insufficiency and early menopause. It can be difficult, particularly in perimenopause, because the levels are fluctuating, but it's deciding at what point it will be helpful to start it. There shouldn't be a fixed endpoint, and this is a really significant change. You should be on the lowest dose for the shortest duration, but the average length of symptoms can be 8 to 10 years. So it might be quite a long duration, and it will be tailored as you're going along. Why it's important. So there's been lots of concerns about over-medicalization of menopause recently, but it's important because we need to treat symptoms. And in terms of absolutely linking in with healthy aging, the long-term benefits of HRT. So we know it reduces the risk of cardiovascular disease by half if you start it within 10 years of your last period or under the age of 60, which has a huge benefit. It helps to maintain your bone density, so it reduces the risk of osteoporosis, and indeed can be used to treat osteoporosis as well. So there are other benefits. It reduces the risk of type 2 diabetes, it reduces the risk of bowel cancer. So it's really important to be considering that. You wouldn't give it if you had no symptoms, apart from POI, but it does have huge benefits from taking it. And obviously to balance that, you need to consider the risks as well. And then the where is, where can it be accessed? So it's not universally available. In the UK, we're really lucky. It's very accessible, but it's not worldwide. And we need increased training generally. We need more menopause societies. And it links back to lifestyle being really important, because for women who can't take HRT, or those who don't want to take it, or are unable to access it, it really does increase the emphasis on how important lifestyle is.
Brilliant, thank you. And back to you, Vilma. When it comes to menopause hormone therapy, what are the main areas of controversy or unanswered questions that your research aims to address?
Yeah, since was talked before, there are pros and cons for the menopause hormone therapy. So at this point, we don't know, for example, the time that we should be taking. There's no doubt that it really helps with the symptoms and decrease the risk of osteoporosis development. But there are other side effects that the research try to understand how that happens and try to find alternatives that could be used as a hormone replacement therapy, especially for those people that, for example, have the history of breast cancer and they are not advised to take that therapy. So different approaches like the food that we can take and the exercise and other, for example, other natural compound that can also have an effect like the estrogen, but don't have the side effect of the estrogen. So this is how the basic research is trying to understand and trying to develop new approaches for the hormone replacement therapy. So I don't think if the question that you...
Okay. Thank you so much. And I think we're actually quite low on time in terms of the rest of the conference. So I don't know whether we've got time for questions, but just to wind up a little bit on my end, this has been part of the BIRAX conference, which took place yesterday. BIRAX is the Britain-Israel Research and Academic Exchange Program facilitated by British Council Israel. And I'm part of the British Council staff here in the UK. It was really good to be part of BIRAX yesterday. I'm really pleased to see everyone back this morning, and I'd really like to thank my two speakers for coming along and contributing. This has been really short but beneficial and informative. Thank you so much. And I'm going to hand over to you in the room, Ravid, I think. I don't know if we have any questions.
Thank you, Jen. We have time for one question, maybe. Tzipi?
I wanted to know what is your intake or thoughts about phytoestrogen?
There's a new, there's a type of, so estetrol is a type of estrogen, which is the fetal estrogen, which has started to be used in an oral contraceptive pill. It's an end product, so it doesn't get broken down to anything further. So there's lots of excitement using it in terms of the oral contraception. And as far as I'm aware, I think there is research and plans for it to be developed into using in menopause hormone therapy. It's much more stable and it will give better management of symptoms and it should give less side effects. And what the timeline for that is, I don't know, but certainly it's now being used in oral contraception.
Right. Thank you very much. Okay, continuing with the importance of agility in aging, we are changing the schedule again, and the next speaker is going to be Professor Steve Horvath, who I believe is also practicing sleep deprivation. So we need to let him return to the importance of maintaining health span. So Steve is in Altos Lab and in UCLA, and the topic of his talk is DNA methylation studies of mammalian lifespan. Steve, welcome.
Hello, everyone. I want to thank Elias Dambler and the organizers for having me. I will talk about my favorite topic, cytosine methylation. As many of you know, cytosine methylation plays a crucial role in development, but also in aging. There are many aging clocks, immune aging clocks, proteomics clocks, lipidomics clocks, and so on, metabolomics clocks. I want to briefly remind everyone of the strength of methylation. First of all, there's the intuitive appeal. It is a beautiful finding that the DNA molecule that carries the genetic information also encodes time. It's just a nice finding. DNA methylation really reminds us of the universality of innate aging processes. Why can we make this claim? Well, we have multi-species epigenetic clocks, so-called pan-mammalian clocks that measure aging in all mammalian species. The third intuitive appeal is that these are not just aging clocks, but also developmental clocks, or a better term is life course clocks. You can have one regression model one clock to measure aging in prenatal samples and in centenarians at the same time. So these methylation clocks truly link development and aging. And then there's the technical appeal of methylation clocks. These clocks are already being used in phase 1 human clinical trials, so they are ready for clinical trial applications. The same clocks can be used for in vitro studies, cells growing in a dish. And as I mentioned, we have clocks that apply to all mammalian species. But the most important question at this point is, can epigenetic clocks serve as surrogate endpoints of human clinical trials? Can you use them as a readout in a clinical trial that lasts, for example, a year or 2 years? And the answer is, we don't know yet. You know, it's actually an exceedingly difficult question to answer. But there have been some developments. And let me rephrase things. A much easier question is, test whether interventions that slow down the rate of aging, emphasis on rate of aging, whether those are associated with longer health span and lifespan in humans. And when it comes to calculating a rate of aging, you really need longitudinal studies. And I want to draw your attention to a recent preprint by Perry Kuo and Luigi Ferrucci, who looked at almost 700 participants of the Inchianti cohort, an Italian cohort, where they had 2 or more blood samples collected several years apart, and they could calculate rate of change in epigenetic clocks. And here on the right panel, you see several epigenetic clocks, Grimm age, Pheno age, so-called second generation clocks. And the hazard ratio that I report here is associated with rate of change, the increase in Grimm age, for example. And you see it is predictive of shorter human lifespan. So these are Cox regression models of time to death. So I've seen now this study and a couple more that make me hopeful that yes, these second generation clocks capture causal association with aging. I want to shift gears and talk about a totally different topic, quality of marital relations. And this study is a study from 2014. I was not involved. And it has nothing to do with methylation. It's just a meta-analysis of whether happy marital quality is associated with better health. And the authors conclude that, yes, there's an association. You see here association with cardiovascular related mortality. And so, yes, if you are lucky enough to be in a happy relationship, chances are this has benefits. However, the effect sizes were exceedingly small. And my conclusion from reading the paper is that it's better to be in a bad relationship but have a healthy lifestyle than to be in a good relationship but follow a bad lifestyle. So that's what I want to tell you. But I was very interested in studying the effect of relationships on epigenetic age. But I chose a species where you can arguably control confounders better. So there's an interesting rodent called the prairie vole. And this rodent forms monogamous relationships. And now you can study whether voles, or these rodents that are in a happy relationship, they found their partner, you can compare those to voles that never found a partner, so-called sex-naive animals. And in this collaboration with Alex Ophir, we looked at many different tissues, blood, brain, ear, liver, and large sample sizes. And basically, we did not find any evidence that the pair-bonded animals differed from the sex-naive animals when it comes to epigenetic clocks. So just no effect. Moving to another topic, just to remind everyone, there is an intervention that rejuvenates epigenetic clocks in a drastic manner, and this is epigenetic reprogramming based on the Yamanaka factors. This finding has been known since 2013. iPS cells are perfectly young, but we also find it with our universal pan-mammalian clocks. Now, the question is whether interrupted reprogramming could also have a rejuvenating effect. And here I show you results from a recent study by Rudy Goya, where he injected an adenovirus with OSKM into the hippocampus of rats and observed then a benefit. Memory performance was improved in a Barnes test, but also we found evidence that the hippocampus was rejuvenated according to several epigenetic clocks. So for me, it's quite interesting that this Yamanaka therapy also applies to brain regions. Oops. I want to talk about so-called third generation epigenetic clocks. So what are those? These are multivariate regression models that predict relative age of a species, where the relative age is defined as the ratio of the age of the animal divided by its maximum lifespan. And this mathematical operation leads to a value between 0 and 1. For example, the relative age of a 61-year-old person is 61 divided by 122, so it's 0.5. And next you can, so you can form these relative ages of different species and build a predictive model based on highly conserved cytosines. And this actually works. So here I want to show you a recent study where we build clocks that apply to amphibians, axolotl, and frogs, the so-called xenopus, the clawed frog, and humans at the same time. So in the panels, I show you on the x-axis the relative age of the species, and on the y-axis, I show you a leave one out estimate based on methylation. So it's, for me, remarkable that you can build these methylation clocks that apply to these very different species. And it's particularly, I like that finding because it shows that there are certain aspects of aging that are truly conserved in vertebrates. Now, there was a curious finding for the axolotl, which was the following, that, so yes, we were able to build epigenetic clocks for axolotl, but only in animals that were younger than 4 years old. By contrast, animals that were older than 4 did not allow us to build an epigenetic clock. And that's a very curious finding, but it supports the hypothesis or the idea that maybe the aging process is halted in these axolotl. So yes, development happens, but then epigenetic aging stops. So this finding may or may not relate to the finding that the axolotl has this remarkable ability to regenerate tails and limbs and other organs. So this is work with my collaborator Max Yun and Julia Halusa. Now I want to talk about maximum lifespan. Famously, the oldest human was a smoker. And so if you just studied maximum lifespan in humans, you would perhaps jump to the conclusion that smoking is actually good for you. But that's not the case at all. But I show you this finding because one of the punchlines of my research is that whatever biological processes relate to maximum lifespan, these processes are quite different from those that relate to individual mortality risk or average lifespan in humans. And the reason is maximum lifespan is a species characteristic, whereas our mortality risk really depends on the individual. So I started the so-called mammalian methylation consortium that involved 200 collaborators, and we generated and released data from 348 mammalian species, 15,000 methylation array samples, all publicly available. And here is the long list of collaborators from all across the world. And we carried out epigenome-wide studies of maximum lifespan. And one of the interesting things was that the lifespan-related cytosines were enriched with binding sites for OCT4, SOX2, and NANOX. So these pluripotency factors for stem cells. So to me, it's remarkable that this study of maximum lifespan relates to these pioneer factors that relate to reprogramming and pluripotency. We have a very good understanding of the methylome in long-lived species. So long-lived species are very good at maintaining a mountainous profile of methylation. Low methylation in transcriptional start sites and bivalent promoter regions, but high methylation in gene body and intergenic regions. By contrast, short-lived species have a flat methylation landscape. We developed a multivariate predictor of maximum mammalian lifespan based on cytosine methylation. And this predictor of maximum lifespan is, again, remarkably accurate on the log scale. So if here I show you log transformed maximum lifespan versus the predicted maximum lifespan. And using this biomarker, one can test, well, which interventions seem to affect maximum lifespan in the mouse. And there was a hint for dwarf mouse status. So you may know there are certain knockout mice that are dwarfs, and they live a year longer. And so we saw a hint that this could affect maximum lifespan according to our methylation predictor. But there's another famous intervention in mice, caloric restriction. And in 4 out of 5 data sets, we saw no effect. And it's well known that caloric restriction relates to mortality risk in mice in about 1/3 of mouse strains. Only 1/3, but not in all. But anyways, it does not seem to affect our prediction of maximum lifespan. And that again makes the case that whatever relates to the species characteristic maximum lifespan is quite different from what relates to the individual mortality risk of a mouse. And when we looked at cytosines that relate to maximum lifespan, they really had very little overlap with cytosines that relate to chronologic age in mice. So quite different. And I was frustrated by the fact that aging effects did not overlap with maximum lifespan. And so we recently published a paper where we link maximum lifespan to aging effects in specific chromatin regions. And this leads to the important technical part. We needed to define rate of change of methylation. So again, rate of change with age. And the hypothesis is that species where you have a fast rate of change in methylation, those may have a shorter maximum lifespan. And this hypothesis is true as long as you look at the right chromatin states. So we use the so-called chromatin states based on histone modifications. And so yes, we do find that rate of change in methylation relates to maximum lifespan, but only when you look at specific regions repressed, for example, by the polycomb repressive complex 2, so bivalent regulatory regions. And here I show you how log lifespan relates to rate of change in methylation. I think I'm out of time. I want to stop. And I started a non-profit foundation that can generate mammalian methylation data for anybody. And I'll stop with that. Thank you very much.
Thank you very much. Are there any questions from the audience?
No questions, only compliments. You make a great job, and it could be said that your clocks could be a basis for quantitative evaluation of rejuvenative events, rejuvenative interventions, and so on. So good luck, and thank you very much.
Thank you very much.
I echo with that, of course. Thank you very much for being the pioneer of longevity, and we all use your clocks, so thank you.
There's a question in the chat by Miriam O'Reilly.
Yes.
Can you provide information on the non-profit, maybe a link? Just do a Google search for Epigenetic Clock Development Foundation in Torrance, Los Angeles. The CEO is Bobby Brook. It's a non-profit, and anybody can get this mammalian methylation array, or simply email me. Yeah. But thank you all, and next time I hope to meet you in person. Bye-bye.
Hopefully. Bye-bye. So our next and last but not least is Professor Shai Shen-Orr from the Faculty of Medicine at the Technion, and the topic will be Exposed to Life, Getting at the Immunological Clock.
Happy to, I guess, end this session a bit late, so I'll try to keep on time. I'm also, as a disclosure, I'm the chief scientist of Cytoreason, a company I co-founded. I'm also the co-CSO of the Human Immunome Project, which is a nonprofit related to mapping the human immunome across the globe, and happy to follow up on this. And so really, I'm going to try and give you a kind of an angle from the immune side. This was mentioned in today's session several times. Here's a bit of data, just to kind of give you some reflection. On the left-hand side, you can see your standard white blood cell count. This has really been measured in humans since 1957, so it's been around. And it particularly tells you everything we know on kind of the immune system from blood at a resolution that if you were to be an immunologist, you would say is totally irrelevant. And that's because really for each one of those different cell types that you see here, we now know there are hundreds of different cell types that can be defined, each with its own function, and those ultimately relate to maintaining health and disease. And just to give you a sense of those, so if you think about every cell as having the abundance being a reflection of its your ability to function in some way, here's a blow up of percent lymphocytes, and everyone here is a physician knows this is quite common to see a lot of variation in this. And so here's some data. Every person here is a yellow line. And you can see there's a huge amount of variation between us. If we were to profile each one in the room, would look different. And there's a change that happens with age. And this isn't just at the resolution of percent lymphocytes. If you zoom in into, say, percent CD8 T cells or subsets of CD8 T cells, you will see the same thing, a huge amount of variation between individuals, as well as remarkable changes that happens with aging. And so it's a complex system, and one would maybe expect this, because this is a sensory system. The entire idea of the system that it senses changes within, external to us and within us, and it needs to respond, and so it keeps changing all the time, and give its function and role in health, actually understanding it and how those changes are happening is key. And so the reason would be ultimately, as I say, if imagine somebody walked into a doctor and said, "Hey doc, how's my immune system doing?" We want to have a good answer for this, and the resolution that the immune system actually is and the resolution we measure in the clinic are so remarkably different. I would argue we don't have a good understanding of this, and there's a lot to be understood. And so with that, here's a way of thinking about this as a thought experiment. Some people here may know the Waddington landscape from the 1940s, where on the top of this graph you had a stem cell and genes that were ultimately related to differentiating this cell. So from an immune perspective, I'll say, rather than thinking about a single stem cell, think about what you see here as a composition of all these different immune system cells, each of which we have different frequencies for, and those changes as we live life, right? So it's almost not just genes, it's your life history, just being exposed to life, and your frequency will change, and maybe, this is the frequency that you have in one particular place in the globe, but another, and maybe this would be disease, but really it's about living life. But if I wanted to think, so age here is our differentiation, the equivalent of the stem cell. But if I actually wanted to think about this from the immune perspective and the path that we take, I'd say the prime path we move on is what I would call immune aging. So how does the immune system change with age? And so some take-homes from from my talk would be that what we've identified as this is a pattern change. This is not random. There's a developmental process by which we all change. We are now able to quantify it, and we keep improving in doing so. People travel this path here at different rates. Each one of us moves at a different rate on it, and it is such a huge change in healthy individuals. This is actually what I would call the first principal component of immune system variation in human, where basically this is the biggest difference that we would see among healthy individuals, and it matters clinically. So basically, if you think about clinical medicine and its relationship of the immune system to it, which I would say is quite critical, your clinical phenotype sits below, above the immune system, and the immune system plays a role, and where your state is on the system is ultimately going to matter. So to really quantify this, back in 2007, we started a study with Mark Davis. I was a postdoc with Mark. Mark had a great idea. Let's start following humans and measure the immune system in high resolution. In 2007, this was science fiction. The tools to do so were really not yet there, and we've been developing them along the way. And we now have a study that's been running for 17 years where we do longitudinal immune monitoring at high resolution in humans. And in fact, this is, to the best of my knowledge, the longest running high resolution study of the immune system. And I'm just going to show you a few slides from a paper we published in Nature Medicine in 2019 that was led by two students from my lab, Yael Benvenisti, who's an MD PhD, and Shai who was a postdoc, where we describe the changes that are happening in 9 years over the 150 people that are participating in this study. And given there's a lot to show, I'll show you really a few plots. This is just looking at the older individuals, 60 and above, in the study, and a subset of the individuals that we've removed any technical differences on measurements from one day to the other. And the y-axis shows you naive CD8 T cell frequency. The reason I'm showing this is because naive CD8 T cells are one of the hallmarks of the aging immune system, where your thymus shrinks and your naive CD8 T cells drop down. And it's been reported hundreds of times that naive CD8 T cells drop with age, and this is the black line. See, that's the average in the population. But we have enough data to model how this behaves in every individual differently. And so that's the colored lines. And you can see the differences in rates between individuals. And in fact, some people actually go against the dogma. Their naive CD8 T cells go up in those years of the study, and it matters. So this is just one cell type like this, but actually we have many different cells, but we're seeing differences in the rates of change between individuals, and in fact that the average really doesn't describe necessarily characteristic of what is happening. In fact, we have so many different cells that we can describe individuals not based on, say, their height or weight and so forth, but really what their immune system looks like at high resolution. So imagine many, many different individuals, and for each we have a vector of many different immune cell types, and we can take this vector and basically try and mesh them together, or tie them together to describe how does immune aging happen throughout the entire lifespan, or at least from young adulthood to older individuals. So build a trajectory that estimates the immune aging process that we go, trying to capture the developmental process of immune aging. And this is what we did, and you can see this on the left-hand side. This is a graph that's basically computed by an algorithm that does dimensionality reduction. The input to this figure is only for every person what their immune cell types are at high resolution. In fact, 18 different cells per individuals were entered in. Not what the age of the person is, not what year they came in or visit of the study, nothing else, just your immune system. And the graph here, every point is one person. They're colored by their chronological age. So on the right-hand side, you see people who are young chronologically, and their immune system kind of looks young. This is the heat map describing them on average. Young people are kind of boring, so I don't spend a lot of time talking about them. And on the left-hand side, you can see as you move on this dimensionality reduced figure, right? So think about this like a PCA. You see the individuals, the chronological age breaks down. So there's a lot of noise in what chronological age is. And in fact, there's disagreement between, I would say, actually a positive noisy correlation between chronological age and what is changing in your immune system, right? So this pseudo time, we can describe individuals and how they change on it. This is how people are organized on this. And you can see the main cells that are actually driving this, and they're changing over time. And just to give you one example, this is one person, the red arrow here, as he shifts in 4 years, right? So from this profile, the color denotes the abundance of the cell scaled, to 4 years later, totally different, okay? And for each of us, this is the types of things they're doing. And as I said, one of the really interesting things here is this is conserved. Despite the fact that if I queried here, we would all look very different, basically we all travel the same non-branched trajectory, this conserved developmental pathway, just at different rates. So how do I see this? Well, here's the old individuals in the study and the young ones. The young, you can see, are kind of noisy. They move around from the longitudinal data. So on the trajectory, the pink are the older individuals. Their slope is always positive. They keep moving forward on the trajectory, okay? Just at different rates. Here's one person moving slowly. Here's another one moving much faster. And in fact, as they move on this developmental trajectory, as your immune system changes, we now test them functionally. So we throw cytokines at the immune cells and we say, how are these cells responding? And bad news, possibly, as the more you move on the trajectory, the less your cells are responding, the more attenuated your immune system is, right? And so you can think about this, maybe it's a good question if it's a good thing or a bad thing, because it could be that in some places around the world, actually having an attenuated immune system may be a good thing for you, and maybe that's how we've evolved. And so we did an analysis of a data set that was published from Mark Davis's lab, looking at Bangladeshi kids versus children in Palo Alto. You can see the children here, 3-year-old children in Palo Alto, and older adults in Palo Alto, young individuals who are about 30 years old. And you can see a marked difference between the Bangladeshi kids and children in Palo Alto. In fact, they're coming close to these individuals with respect to describing what their position is on the trajectory, right? So basically, as you think about it, we can now give you a number, draw a blood sample, measure 18 cells, and give you a number of what that describes what your immune age is. We call this image, and this is not just about aging, it's really about being exposed to life. So you can think about this almost like a road that we all travel on, right? As I said, we can measure this now actually by several different data modalities and quite cheaply. Eric Feldman, who's a student in the lab, is sitting here, and he's developed a flow cytometer test for this. And the image score is basically where you sit on the trajectory. Now, one question you would think, given the immune system, is that if we're all traveling on one road, just at different rates, What if I took an off-ramp? What does it matter if, like, say, you vaccinated me, or what does it matter for clinical medicine what your immune system is like? And so we looked at this, right? Because it's important to understand if everybody's going in the same way or not. And so the first thing to look at is something big, like survival. And so we developed a gene expression score that basically predicts your image score, your immune age, on where you sit on this trajectory. And because our study is small, we moved from this 150-person study to taking on the Framingham Heart Study, where if you actually take the individuals in the Framingham Heart Study and you score them for immune aging, you can see the differences in survival and also in cardiovascular risk. This is part of the published paper. And then if you now add in all the clinical factors, you can see that immune and you model image. So for those who are not familiar with Framingham Heart Study, this is the longest running kind of cardiovascular study. And a lot of what we know about cardiovascular medicine comes from this. There's a lot of clinical information we can model. We model this, and we modeled their immune age because they all measured blood gene expression, and so we can estimate it. And this is a significant survival association, and the odds ratio is 1.05. In fact, they all in the Framingham Heart Study, they also measured methylation, just like Steve was talking about in the previous talk. And so here's just a plot where a table where we take in a lot of different clinical factors and the different kind of published methylation clocks. And what you can see is that immune aging is always a significant factor, even when the methylation clocks are modeled as part of the Cox model. And in fact, often it's greater, but most important is that it always adds additional information. So kind of suggesting that we're not capturing everything that we need still with the methylation biological clocks. And in fact, when we did an analysis, we developed a methylation-based clock for immune aging, and it does not overlap with the CpG sites that are coming on from the published clocks, suggesting there's additional information that can be captured from this. Another way of kind of looking at the same direction is so important for survival, cardiovascular risk, but let's talk about something much finer grained. If we're talking about the immune age, well, what's really important are immunotherapies. So we ran a study that was led by Mayan Briller, a PhD student in the lab, where we looked at estimating immune age, how do individuals respond to COVID vaccine mRNA, the Pfizer vaccine, where the study was designed to take individuals across many different ages and estimate their immune aging. This is a collaboration with Yuval Dor and Dana Wolf from Hebrew University and Hadassah. And here's just kind of two plots from the study. On the left-hand side, you can see there are neutralizing antibodies for COVID, for the COVID vaccine. And when we model it with chronological age, or when we model it with immune age predicts neutralizing antibodies much better than your chronological age. In fact, if we divide the data into immune age, young or old, or chronological age, young or old, you see significance in immune aging not captured by chronological age. And in this particular data set, immune aging explains 20% of the variation in the data, whereas chronological age explains 10. There's still a lot for us to do work on in understanding immune variation. Another interesting thing from the study is that when we try to predict neutralizing antibodies, we get a bunch of features that predict it. And you can see those on the left-hand side for positive features and also for negative ones here in blue. But if you do this in the older individuals in the study, the features are not the same. So they're no longer predicted. The same features that are used to predict the immune system components that relate to how you will respond in terms of building neutralizing antibodies for the vaccine seem to not play a role in the elderly. And we took this finding and went with it to a much larger study looking at over 600 individuals with flu responses. You can see a heat map here where the individuals are organized based on their immune aging score. So this is the columns, and the features that correlate with your neutralizing, with your flu responses are listed in the rows. And what you can see is basically is the immune system, and what's important in different pieces of like your developmental process actually changes what those features are. Just like if we think about, say, gender differences, how biology in men and women works would be different. It looks like in aging, that's the same thing. What is important in young to predict responses is not really what plays a role in when we're vaccinating individuals, older individuals, and we are hoping for them to respond. And of course, we have a problem because older people do not respond to vaccines and young do, and we develop the vaccines in the young. Kind of led me to this analogy where I think about the immune system of older individuals, and I think, no, it doesn't, it's not that it doesn't work, right? It's that they're playing a whole different strategy to actually score a goal, right? So if you were thinking about, say, soccer players, young soccer players that run around for the goal, the older individuals, if they chose to play soccer, they would play a whole different strategy. You'd still have a goal. Maybe they miss sometimes, but they have a whole different strategy. So thinking about the immune system as being a conserved thing where it's such a dynamic process is actually probably not a good thing, and we need to rethink how we do so. So I'll end this part and say, in summary, that what I hope to show you in this brief talk is that immune aging follows a pattern trajectory of change. We travel at different rates on it, and it's the first principal component of the system. We can basically map you now to a reference. We can do this with cell frequencies in cytoph and flow cytometry by gene expression in whole blood and PBMC by methylation, and proteomics is coming. It has molecular and chemical facts, and it's basically a lifelong pathway to study and manipulate. And with this in mind, I will put a kind of brief ad to where, my next slides are missing. Here it is, okay. So we've basically decided to put together the Technion, a Healthy Aging Institute. And I was gonna say it relates, from our perspective, the immune system, the big thing is how it relates to physiology. I direct this institute. We're just launching now. It's called iTech Age, is the kind of the think tank around it, which we'll partner with a lot of different groups. It has a lifespan cohort of over 1,000 individuals that we're tracking, a systems medicine center for kind of bringing in kind of a lot of different types of multi-omic measurements. And really principal to this is over 60 researchers at the Technion who've all kind of been joining into this established groups and themes. The lifespan cohort is a shared Technion resource for all of them to study, and they span from looking at cellular mechanisms of aging and systems aging and immunology and endocrinology to brain and cognition, biomarkers of aging, personalizing foods and drugs, assistive technology, and ultimately even looking at the communities where we have people from the Faculty of Architecture where we'll be doing those types of research. So thank you, and this is the lab. It's all really done by the students. Thank you. I guess as the chair, questions from the audience. Hi, Gil.
Okay, my question to you is the following. You said that the immunologic aging and the what's so-called the cytosine clock are not best fit. My question, and the other thing that you said that there is different velocity or different fitness between, age people that fit to immunological aging. My question, though, are those that fit better to the immunologic aging are also, can predicted by the biological clock?
You mean by epigenetic clocks? The short answer is we don't have data for this because I don't have data sets that have 2 methylation time points and two immunological time points. I actually, as you asked this, I realized I can actually generate that data. So I will let you know next time.
Hi. Very interesting indeed. Did you thought about what factors actually influence the immune system? Because let's say, for example, a person that immigrate from one country to another and there was a climate change and food change and everything. So this is external influence on the immune system. So those kind of people, do they have better immune system or does it hurt the immune system and they have less?
It's a wonderful question. I think because it's a sensory system, there's many such fascinating ones. I keep thinking about the migrating ones. I don't know. I will say I don't think we even understand. So certainly, larger immune aging seems to predict cardiovascular risk. We know we can manipulate it. Like people who respond to inflammatory drugs drop in their immune age clock for a few kind of the immune aging process. But I'll give you an example. So for cardiovascular disease, we know high immune aging is bad. Bone marrow transplant, which is a study that actually Eric is running here. When we give somebody gets a donation, do you want to have a high or low immune aging? We don't understand yet. Certainly, data that has looked. There's people who've looked at the change that happens when you shift from a rural environment to an urban one, and there's a huge immunological change relating also to your diet, and we haven't mapped that data, but if I were to kind of estimate, I would say that you're probably getting an increase in immune age when you see this. There's also increased incidence, of course, of chronic diseases, but we have a lot more to do.
Thank you.
Thank you. 30 minutes late, I end this session. I guess, Ilya, we're taking still a break, right? We well-deserved one.
Okay, we will continue. So still, good morning. My name is Dr. Yael Benvenisti, and I would like to present Dr. Ira Sobel, founder and academic director, FinTech for Longevity, for the next presentation about, just a moment, so it will be here about longevity and open data, leveraging aging data to longevity finance.
Hi, everyone. Thank you, Yael, and thank you, everyone, for joining us. This is the last session of the last day. Thank you, Ilya, for inviting me and having me here. I'm going to talk today about longevity from a different angle and how longevity can be leveraged into financial planning, asset management, what I call longevity finance. So thank you for joining the session. I'm Dr. Ira Sobel. I'm the founder and academic director of FinTech for Longevity Academy. And today we'll explore the evolving landscape of financial planning in the context of increased longevity and the tools that we can use to support this transition. So I want to start with the current landscape of financial planning. And as we know that in the current landscape, financial planners often work is very limited about their clients' health. So financial planning is about asking people about their health and planning into the future, about their wealth and about their income and resources and some risk products like insurance and long-term care. But usually financial planners don't know anything about people's health. They ask about smoking, yes or not, probably if something is very acute, but beyond these data, nothing. So everyone gets, in the end of the day, the same financial planning, no matter one's health condition. So basic data like age, gender, and smoking status are standard, but they don't capture what we need for the full picture needed for accurate financial longevity planning. And that's why I call it longevity planning rather than financial planning. And this limited information constrains financial planners' ability to plan effectively for each client's unique health and financial needs at the same time. So moreover, the generalized approach that relies on, the generalized approach that relies on mortality tables fails to account for critical factors like existing health conditions, lifestyle choices like sleep and activity, and future medical needs. So many financial planners lack insights into these areas, which results in plans that can overlook significant aspects of clients' life, can lead to action plans that don't really address the economic realities that clients may face, especially as they age, potentially putting their financial security at risk. So this is a pie chart that represents respondents from a recent poll that we conducted at our company with 41 financial professionals. This is an ongoing survey, so we expect more answers, more respondents. We asked about the primary challenges that financial planners face when planning for their clients with extended life expectancy. So the responses underscores a key issue. that these financial professionals struggle to account for the complexity of longevity, which involve not just financial resources, but also health considerations that significantly impact long-term financial stability. And I want to show you one of the quotes that we got from this survey. This survey is, somebody wrote, "I still see unrealistic longevity expectations from clients, which can cause frictions when trying to make best financial decisions. Deciding how long to make someone live when we do a cash flow plan is probably the hardest thing to predict." So as we see, there's a blind spot here, and we need more information from longevity to be leveraged for asset management and financial planning. So in order to see how we can bridge and how we can close this gap, we want to introduce FHIR. FHIR is a standard that is called Fast Healthcare Interoperability Resources. In simple words, it's a standard framework that allows various healthcare systems to communicate with each other, facilitating seamless health data exchange by connecting information like medical records, lab results, and treatment plans. So FHIR enables, in a healthcare setting, a comprehensive view of individuals' health, accessible in real time. And let's take an example. Let's consider a patient with a complex medical history who regularly sees multiple specialists. By utilizing FHIR and converging between the data from different clinics, experts, these providers can share this patient's data across systems in real time, allowing for cohesive care management. So not only does this empower patients to take ownership of their health data, but it also enables holistic view that could benefit financial planning. So given that we have this FHIR, and together with what we call open banking, this is open healthcare. It allows, for example, if you can think of a few bank accounts or saving accounts or pension funds put together on one dashboard, this is the same process that's happening with open healthcare. And if we take these two together, we can leverage, we can gain insights from one domain to another. So about financial health, on overall health, and from data to gain insight on life expectancy and more nuanced financial planning. So with access to this detailed health data, financial professionals can create personalized longevity strategies. It can project future medical costs based on specific health risks, setting up tailored saving accounts, level of liquidity for long-term care, resources for long-term care, or even recommending insurance products that are tailored to specific individuals' health status. So these strategies do not exist at the moment, and I think that this could be a big change, a big revolution in financial planning and asset management once there could be a convergence between our health and wealth. So what are the FHIR application in the real world? So FHIR's application extend into financial planning in 3 key ways. Number one, it allows for the integration of health and financial data, as I said before. It supports predictive analytics and risk management, but also it enables the creation of customized financial products like insurance policies or health saving accounts and saving plans for the long term or for midterm. So with FHIR, we would be able to tailor financial strategies more closely to individuals' health. But of course, there are challenges and considerations. Number one is the integration and financial planning becomes crucial. So there are challenges in implementing FHIR, data security and privacy, of course, primary concerns given the sensitive nature of health data. But the open APIs that enable FHIR also introduce vulnerabilities such as lack of adherence to regulations like HIPAA and GDPR, depends on where we are. Other challenges include inconsistencies in FHIR implementation across systems and ethical consideration around informed consent, data ownership, and reversing discrimination based on health status. So this is about ownership of data, putting together all the data together, both in banking but also in healthcare, and then providing more ownership on people, for people to own their own health or financial data. So I want to move now to the future directions and implications. So we understood on one hand, we have open banking, which is an aggregation of financial data in one place. We can see it in a few apps that allow people to monitor and see everything together. In Israel, we have the pension dashboard, we have the Hara Bituach, the insurance mountain, or we have Hara Kesef, the money mountain. At the same time, it's a bit lagging behind, but in the healthcare sector, this is what is called FHIR, which is the open healthcare. And what we're looking is how to bridge between the two. So here are a few future directions. Despite these challenges, the integration of FHIR in financial planning holds significant promise. As demand grows for personalized financial planning, including health data, we anticipate more developments such as platforms that combine health and financial data. For example, in asset management, first question is about health condition. What is the levels of liquidity? How much out-of-pocket expenses, medical expenses are there? For example, innocent, other maybe very expensive medicines that people need to put money aside. How much money they need to put aside? This is something that is very important. So we see that the principles from open banking, like secure data sharing, could influence FHIR, empowering individuals to manage their health and financial data in a secure and integrated way. So I want to conclude because we have only 10 minutes and I want to leave time for questions. So to conclude, FHIR represents a measured advancement in healthcare interoperability, offering a flexible framework for data exchange that goes beyond healthcare to support also our financial life. By merging health and financial data, as I said before, FHIR can help individuals manage both domains effectively. And now we need to build a module that would take the insights or the data from health and see what exactly are the insights and how we can leverage these data into calculating probabilistic models and others to see exactly that people will have a more nuanced and effective financial planning. So this has the potential to revolutionize how we use data to improve overall well-being. And I think that this is very interesting, and we look forward to seeing more and more apps and modules in this area. So I want to thank you for your attention, and I look forward to any questions and discussions that you might have in this transformative path. Okay. So thank you very much again, and I would like to introduce you to Dr. Yael Benvenisti, the Deputy CEO of Insurtech Israel, who will speak about the climate changes and how it affects aging and older adults. Great. Thank you very much.
Well, thank you, Ira. I'm Dr. Yael Benvenisti, and I'm very happy that this is my spot because my presentation is a summary of epigenetics, longevity financing, planning, and insurance, because the connection for insurance is that they are predicting life and health of one that is doing the insurance, and they need all this data in order to make the insurance more correct. So I come from Insurtech Israel, which is a company dealing with technologies for insurance companies. And I will talk about climate change, epigenetics, and human health. While some of the previous presentation have provided insights into the cellular mechanism of aging and age-related diseases, and some about how our behavior affect aging, I would like to take a step back and zoom out, and I would like to explore how the ever-changing environmental landscape, especially climate change, is influencing our genetic expressions. Because by focusing on environmental factors, we can gain a more holistic understanding of epigenetics. So as you know, climate change is a complex issue. This slide provides a brief overview of some of the key impacts of climate change. We see a rising global temperature, extreme weather events, sea level rise, ocean acidification, air pollution, and food insecurity. These changes are not just affecting our environment, these are also affecting our bodies and our genes. You can see in the graphs that the global warming and the severe storm count in the United States, and you can see that both of them are increasing. Now, just in one slide, I would like to describe epigenetics. Epigenetics is the study of how environmental factors and behavior can cause changes to gene expressions without altering the underlying DNA sequence. These changes can be passed down to the next generation, and this is very important because it will not just influence us, it will influence our next generation. Understanding the link between climate change, epigenetics, and human health is crucial for developing effective strategies to protect our health, well-being, and aging. Now, in this slide, I would like to talk about the connection between climate and epigenetics. Let's start with extreme heat. Extreme heat can trigger a stress response in our bodies, known as heat shock response. This response involves the complex network of molecular signals that help a cell cope with the increased stress. One way this stress response can affect our genes is through changes in DNA methylation that the previous presentation talked about. DNA methylation is the process that involves adding a methyl group to DNA, which can silence gene expressions. Another way heat stress can influence gene expression is through histone modification. Histones are proteins that DNA wrap around to form chromatin. Modification to histones can also influence gene expression. These epigenetic changes caused by heat stress can have long-term effect on our health. For example, they may contribute to development of chronic diseases such as cardiovascular disease and neurodegenerative disorders. Air pollution. Air pollution, particularly exposed to fine particles matters, can induce oxidative stress in our cells. This oxidative stress can damage DNA and alter epigenetic marks, such as, again, DNA methylation and histone modifications. These epigenetic changes can lead to changes in gene expression, increasing the risk of developing various health problems, including respiratory disease like asthma, COPD, and lung cancer, cardiovascular disease, neurodegenerative diseases like Alzheimer's, Parkinson, and dementia, and other kinds of cancer. It is important to note that this effect of air pollution on epigenetics can be long-lasting and may impact future generations. Now, next, let's talk about the exposure to UV radiation, most of the time from sunlight. This can damage DNA and trigger cellular stress response in the same way. These epigenetic changes can have a variety of health consequences, including skin cancer, premature aging, and immune system dysfunction. Another connection between climate and epigenetics is nutrition. Extreme weather events such as droughts, floods, and heat waves can disrupt agriculture and reduce crop yield. This can lead to food shortage and increased food price, making it difficult for many people to access healthy and diverse diets. Furthermore, climate change can alter the nutritional content of crops. For example, higher level of CO2 in the atmosphere can reduce the protein and mineral content in some crops. And of course, this will affect our health and sensitivity to aging disease. The last connection I would like to talk about is the hormone change. While the direct impact of climate changes on hormone levels is less studied compared to the effect on other systems, there is some potential for indirect mechanism. For example, climate-related stressors such as extreme weather events can trigger the body's stress response, leading to increased level of stress hormones like cortisol. Cortisol can influence this, again, DNA methylation. As mentioned earlier, climate change can affect food production and availability. Nutrient dysfunction, particularly in essential vitamins and minerals, can disrupt hormone balance. So you can see that this cycle between the external and the internal environment is crucial. Epigenetic changes influenced by environmental factors can significantly affect lifespan in humans. Now let's talk a little bit about how. The first likelihood is by one to have a disease. Exposure to environmental toxins and stressors can trigger epigenetic changes that increase our risk of developing diseases like cancer, heart disease, and neurodegenerative disorders, ultimately reducing lifespan. Second, epigenetic changes can accelerate cellular aging, leading to premature senescence and functional decline. Third, environmental factors can disrupt metabolic processes through epigenetic mechanism, leading to obesity, diabetes, and other metabolic disorders. About stress, we talked before, but last, I need to mention that climate also affects our lifestyle choices, like diet and exercise, and as we all know, these two are affecting our lifespan. A very interesting research I would like to present is about the city renovation that can significantly impact the local climate that will impact cardiovascular disease rate. This is a phenomenon called Iceland effect. Densely built urban areas tend to be hotter. This is because the asphalt absorbs the heat, trapping it and releasing it slowly. Higher temperature can lead to heat-related illnesses, dehydration, and increased blood pressure, all of which can contribute to cardiovascular risk. Another effect of high building is on the wind. Tall buildings can disrupt natural wind patterns, leading to increased pollution levels. Exposure to pollution can damage blood vessels, increase inflammation, and contribute to heart disease and aging. And there was a previous presentation about our immune system, and always there is a talk about what is before what. Is it the immune system that will influence people after the climate change, after there is a climate change, or the climate change will influence the immune system, and then the person will get more sick. Now, this was the problem, and I would like to present 3 technological companies that are trying to give a solution. The first one is Enmotion. Enmotion is a company who developed a global climate modeling solution designed to prepare users for future extreme climate events while also explaining potential outcome scenarios. If you remember, in the United Arab Emirates was a massive flood last year. The company saw it 6 months earlier. This company can predict climate changes in different regions of the world and allow to prepare and expect for the damage. The second company has more local solution. Brisometer is using wearable devices and a home sensor to monitor exposure to pollutants, stress, and other environmental factors that will affect our health. And I would like to show you a short video.
Traffic, weather, and local emissions mean air pollution levels can change quickly throughout the day. Exposure to that kind of pollution can cause a range of short and long-term health problems. With access to localized air quality information, people can make healthier decisions about the air they breathe. Brisometer provides the world's most accurate location-based air quality data, making air quality as simple to read as a weather report, and even simpler to integrate into products using the Brisometer API. So, how does it work? Brisometer uses air pollution data from government sensors and layers it with wind, weather, and traffic dynamics, as well as satellite readings. Next, Brisometer uses proprietary dispersion algorithms and machine learning techniques to predict ambient air quality readings down to the city block level. And it's precise. Using the Leave One Out cross-validation method, Brisometer calculates a predictive measurement for a specific location, then compares it to readings from an active air sensor in the same spot, ensuring precision through repeated statistical testing. Brisometer's API offers unseen features to be integrated into products such as air quality forecasting, pollution heat maps, historical air reports and analysis, actionable health recommendations, and real-time notifications. Industries can use real-time data to power air-aware products that engage users and help them lead healthier lives. So everyone can use big data to make better decisions. and breathe a little easier with Bursometer.
Now, the third company is Genomics. This company specializes in at-home genetic testing that can predict predisposition to diseases like heart disease and cancer and so on using a saliva sample. Early detection and simple testing can help individuals take preventive measures to avoid illness. A study found that if heart disease screening were conducted using genetic testing in middle-aged population, genetic changes requiring intervention would be found in 8% of those tested. This is a huge portion of the population. So, in conclusion, to prevent age-related disease, we must consider the impact of both our immediate and global environment. It's clear that even if we can develop medication or make cellular intervention without understanding and addressing external influences on the body, we will not achieve lasting changes. Thank you. Questions? Okay, then I would like to invite Ilya.
Thank you very much, Yael. Thank you very much, Ira, for this session. Next year, we will have more discussions of the industry and different industries on the field of longevity. And now we go to something else. This session is called Longevity Development, which is basically industry and education. As in the framework of education, we would like to introduce a prize which we created recently. Let me just open the relevant slide. This prize it was basically inspired by my co-worker, my collaborator named Joseph Gitterts, an amazingly brilliant young scientist. Was a great promise in the field of bioinformatics of longevity, computational modeling of longevity and aging processes. Together we published several papers in high-impact journals, also thanks to his programming skills, modeling skills. And he was killed in Gaza in December last year. And many of those dreams and promises and aspirations were killed with that, as many dreams and promises were killed with this war. But hopefully the dream will live on and the work will live on, and it will be continuing the work of other scientists. That's why this Longevity Aspiration Prize was created. Many thanks to Joseph's mother, Larissa Epstein, who put this together, who created this, and also there'll be other contributors, other stakeholders. The foundation that they recently created is in progress. It was just formed, or is still emerging, by Gitter's family, called Joseph Gitter's Foundation. And hopefully it will build up, cooperate maybe with other foundations together to provide support, increase support for young, inspiring longevity scientists and scholars, so we can build the next generation of longevity research. That's what this prize is about. Larissa, please say a few words.
Good afternoon, friends. Ilya just already spoke what I have to speak about, but now I repeat. Today, not me, but my son was meant to stand here sharing his work with you. From an early age, Joseph dedicated himself to using computational methods and AI to prevent illness. Together with Dr. Ilya Stambler, other scientists, he co-authored several papers on aging and longevity. In these projects, Joseph took on the mathematical and computational analysis of data from medical research. He was recognized as one of the most promising students at Reichman University. Through the Reichman Entrepreneurship Program, he began developing a startup focused on extending human life. But fate had other plans. My son fell in battle in Gaza. Okay, this Ilya already said. With his death, a life of great promise, remarkable achievements, and incredible spirit was lost. Like many others, his dreams were killed by this war against international terrorism. In honor of Joseph's legacy, we have established the Joseph Guitars Memorial Fund. This fund will support groundbreaking research and scholarships for outstanding students in the areas which Joseph believed will change the future of health. Thank you for commemorating my son's vision and helping to make his dream a reality. I am also deeply grateful to people like Hanan Tal, who are serving in reserve duty during this long, long year. We are proud our fund could help those heroes. I wish you all success, health, and happiness. Thank you.
Thank you very much, Larissa, for this initiative, for this continued contribution. And now we proceed with the awards. The regime will be in this competition. We have 3 tracks. Maybe in the next one there'll be other tracks, but in this competition there'll be 3 tracks. One is computational biology of aging and longevity, the track which is directly related to Joseph's works. The second is fundamental biology of aging and longevity, and the third is social gerontology. In each track we have several contestants. Not many, we would hope there were more, but hopefully in the next prize there will be more. Also, you know, the situation doesn't encourage, but hopefully next time we'll have more contestants. We will start with short presentations up to 5 minutes without questions by the contestants in each of the tracks. In the end of each track we will announce the winners, the first or the second prize. All the works are great, amazing. All the contestants will receive prizes. So I will start with computational biology of aging and longevity, and the first contestant is Neta Nevo from Shai Shen-Orr's lab. She will speak about identification of drivers for accelerating the development of B cells in old individuals, and the co-authors include Neta Nevo, Neta Milman, Yael Talpert, Tim Cooper, Doron Melamed, and Shai Shen-Orr. So please, Neta, we can close this.
Hi, my name is Neta. I'm a pediatric hemato-oncology physician, and currently I'm doing my PhD under the guidance of Professor Shai Shen-Orr. My project deals with one of the challenging clinical problems that increase morbidity and mortality among old individuals, low immunity. And we focused on the B cells that are responsible for mounting an immune response to vaccines, infections, and cancers, and whose frequency in the peripheral blood is low among old individuals. And to address it, we identified putative drivers for accelerating the development of B cells in old individuals. B cells derive from hematopoietic stem cells in the bone marrow that differentiate into progenitor B cells. And this longitudinal process is regulated by specific cellular niches that include many mesenchymal stromal cells. The bone marrow includes thousands of factors that theoretically may manipulate the development of B cells. The space is huge. And our goal was to identify those with the high probability to enhance the process of B lymphopoiesis among old individuals. And so for that, first we identified putative drivers in healthy donors. Then we focused on those that are relevant for old individuals. And finally, we validated the drivers. So first, we analyzed single-cell RNA-seq data of healthy human bone marrow samples. And we created a B-cell trajectory that ordered the cells based on their developmental state. And our trajectory successfully captured the known B-cell developmental stages, started from hematopoietic stem cells that differentiate into pro-B, pre-B, and immature B cells. And we identified 2,618 genes that create the trajectory and govern its development, and we named them B-cell developmental genes. And then we aim to find activator for those genes, since those activators are putative drivers. And for that, we studied the cell-cell interactions in the bone marrow. And we identified 69 putative B-cell drivers, which are ligands that are expressed by mesenchymal stromal cells and interact with receptors that are expressed by progenitor B cells. And next, we aimed to filter those that are relevant for old individuals. And for that, we studied the process of B lymphopoiesis upon aging in 3 different aspects. We studied the longitudinal development of B cells upon aging and the different regulation of B lymphopoiesis by mesenchymal stromal cells and by the crosstalk between the peripheral blood and the bone marrow. So to study the longitudinal development of B cells upon aging, we compared the trajectories of individuals in different ages. And we found B cell developmental receptors with different dynamic along the trajectory. For example, here you can see that the expression of 604 is similar within young adult. However, the expression of SPN, its dynamic precedes in young, and therefore we prioritize its ligand ICAM1. And we also studied the different regulation of B lymphopoiesis by the peripheral blood upon aging. So for that, we measured the protein level in the peripheral blood of 3 groups of patients: young individuals, old individuals, and old patients that by treating them with B-cell depleted therapy, rituximab, we induced B lymphopoiesis. And we identified putative drivers whose expression post-induction of B lymphopoiesis, so old individuals that were treated with rituximab, was restored to useful, suggesting the role in B lymphopoiesis, for example, PDGFB. So overall, we identified 27 putative drivers that are involved in B-cell related interactions. And then we decided to further test the role of 7 candidates that they display different biological function, and the role in B lymphopoiesis has not been established yet. So for that, we performed a single-cell gene expression stimulation assay. We stimulated the bone marrow progenitor cells with the different putative drivers, and we looked at the resulting downstream pathways and genes, and we found that 5 out of our putative drivers elevated B-cell related pathways and genes. And finally, we focused on 1 putative drivers, a neurotrophic factor, whose role in B lymphopoiesis has not been established yet. And we validate it in a biological system that mimics the development of B cells from hematopoietic stem cells. And following addition of BDNF, we found accelerated development into progenitor B cells that express CD10 and CD19. So to sum up, we use systems biology approach and biological experiments to find the B-cell drivers for accelerating the development of B-cells in the bone marrow. And this may improve the function of other crucial age systems as well and lead to healthy aging. And with that, I would like to end and thank for my dedicated supervisor, Professor Shai Shen-Orr, and the other lab members that support me in this project, and thank you very much.
Thank you, Netta. The next presenter in this track is Eric Feldman, also from Professor Shai Shen-Orr's lab, and he will speak about towards healthier aging, adopting an immune state metric to predict disease and treatment outcomes. And the collaborators include Eric Feldman, Tim Cooper, Netta Millman, Yuval Klein, Aviv Barak, and Shai Shen-Orr. Okay, that's fine. That's absolutely fine. The award does not depend on presenting or not presenting, only on the actual material, on the actual scientific value. And the posters are available here in the lobby. That's fine. And the third person in this track is Omri Segev. Who is not here once again because of active military duty, and his supervisor, Professor Tali Kukerman-Yaffe, and his topic was development and first stage validation of a digital version of the digit symbol substitution test for use in assessing cognitive function in older people with diabetes. And the collaborators are Omri Segev and Tali Kukerman-Yaffe. So we will now announce the winner in this track. The prize money will go to the contestants' bank accounts directly. As I mentioned, all of them will get prizes. Only the difference if it's the first or the second prize. Both are very honorable. The winner is Eric Feldman. Welcome. That's the first prize. And the second prize goes to Netta Nevo. Thank you very much. We go to the second track, which is Fundamental Biology of Aging and Longevity. And the first contestant is Noa Rahmian from Valery Krzyzanowski's lab from Weizmann Institute. And her topic is the role of microglial senescence and aging in Alzheimer's disease. And the cooperators are Rahmian, Medina, Cherqui, Akiva, Deutsch, Edilbi, Kreze, Salame, Ramos, Kahalon, Krzyzanowski, Michael Schwartz, all from Weizmann Institute. Welcome.
Thank you. Thank you for the organizers and for Larissa for this prize. And my name is Noa Rahmian, as you said. I'm going to present to you my PhD project. It was published in Nature Neuroscience about the connection between senescent microglia accumulation, aging, and Alzheimer's disease. First, a bit of an introduction. Alzheimer's disease is a chronic neurodegenerative condition marked by brain inflammation and cognitive decline. Microglia are the innate immune cells of the brain, the major immune cell of the brain. They are having a significant role in Alzheimer's disease. Aging is a major risk factor for Alzheimer's disease, and it's categorized by the accumulation of senescent cells in different tissues, contributing to the chronic inflammation in aging. Senescent microglia are the potential connection between aging, inflammation, and Alzheimer's disease. Yet it's still not fully understood how. In my project, we showed that there is a conserved signature of senescent microglia across aging, Alzheimer's disease, and dementia. this signature, this conserved senescent microglia are accumulating in aging and in Alzheimer's disease mice, 5X5 mice. They also upregulate TREM2 expression, and TREM2 expression was correlated with senescent markers. When knocking out TREM2, there was a significant reduction in the senescent microglia accumulation. And when using a drug, ABT737, which causes senolytic effect of senescent cells, meaning it kills senescent cells all over the body, including the senescent microglia, there was an improvement in cognitive measurement using the novel object recognition task. There was less accumulation of senescent microglia and less neuroinflammation. So to sum up this project, aged mice and Alzheimer's mice accumulating microglia with a conserved signature. These senescent microglia are correlating the expression of senescent markers with TREM2 and ApoE that I didn't show you, but it's in the paper. When knocking out TREM2, we see less accumulation of senescent microglia, and using senolytic treatment ameliorated Alzheimer's disease pathology. Thank you.
Thank you very much, Noah. The next presenter in this category is Yulia Mayevska. Is she here? She's here. The supervisor is also Valery Krzyzanowski, and her topic is P16 dependent increase in PD-L1 stability regulates immunosurveillance of senescent cells and promotes chronic inflammation and aging. And the co-authors are Yulia Mayevska, Amit Agarwal, Avimayo, Urialon, Ido Amit, and Valery Krzyzanowski. Welcome. You should see this.
Okay, thank you very much to organizers for this kind introduction and invitation. Great. So senescence is a state of irreversible growth arrest that is induced by damage, and simply these cells overexpress inhibitors of cell cycle progression, and they don't die, they are metabolically active, they secrete a wide array of cytokines, calling immune system to come and kill them. However, this process is really disabled in aging, and they accumulate in aged individuals, leading to different age-related diseases. And we already know that elimination of these cells can improve both health span and increase lifespan. So this attracted lots of attention into development of senolytic drugs, as Noah said, that kill senescent cells. However, they are not specific yet, and they have side effects in human. And this was my question. So maybe it's worth to understand why do they accumulate? What's the molecular mechanism of accumulation that could lead to better strategies? So if you think about senescent cells accumulation, we need to think about turnover and dynamics in the body. Well, it depends on damage that leads to production of the cells and immune-mediated removal. However, in age, it's disabled because there's higher production rate that leads to higher production of the senescent cells, and immune system is also dysfunctional and doesn't remove them well. But what was not known was this interaction between senescent cells and the immune system itself. And I asked myself whether there is some intrinsic mechanism that can regulate the removal, whether we can target, and what would be the output. So to make long story short, to address all these questions, I wanted to understand cellular senescence at single cell level in lung as a model organ in both aging and chronic lung disease. And what I noticed is that myeloid cells were enriched, especially alveolar macrophages were enriched in senescent phenotype. And they were expressing high level P16 as inhibitor of cell cycle progression, but also the same cell type was very highly expressing immune checkpoint protein PD-L1. And this attracted our attention because PD-L1 is critical central protein controlling immune responses, overexpressed on cancer cells, leading to their evasion from immune clearance. So what we've seen, we studied it in detail, and we've seen that these cells that highly express P16, they were also highly expressing PD-L1, regardless of age, but it was more pronounced in aging in both population level and single cell level, and was independent of the cell type. Simply this phenomenon was in any cell that entered senescence. So the next step, I wanted to understand whether there is some molecular mechanism behind this process, and well, indeed, when I overexpressed P16, it led to accumulation of PD-L1, but the depletion of P16 caused accelerated rate of degradation. And this suggested that in this whole process of PD-L1 accumulation, there is aberrant degradation rate, and simply proteins that are involved in targeting PD-L1 for ubiquitination and subsequent degradation are aberrantly expressed, leading to less ubiquitination and accumulation of this protein. Well, so when we have PD-L1 on the surface, it can lead to suppression of immune system responses, but there are ways to go about it. And we can inhibit this axis using antibodies either against PD-L1 or PD-1. And this is indeed what I used, what I checked. However, for PD-L1 part, I use activating antibodies that not only block the axis, but also activated Fc gamma receptor positive cells towards killing PD-L1 positive cells. And simply what we've seen is this very interesting that only blocking PD-L part led to depletion of senescent cells in shorter model of lung inflammation. And it corresponded well with enhanced immune activity, cytotoxicity of CD activation of CD8 T cells. And the same phenomenon we observed in physiological models of aging and also chronic lung disease. So we could deplete senescent cells. It was related with T cell response, activation of T cell arm, and reduce chronic inflammation, systemic inflammation. So it all leads to simple conclusion that the damage that leads to induction of cellular senescence also leads to, via P16 dependent pathways, to decrease of ubiquitination of checkpoint PD-L1 and its induced stability. And when it accumulates and is upregulated on the cellular membrane, it leads to it shuts down immune response, leading to evasion of the cells and accumulation in the body. But we can target it, and elevation of inflammation and different senescence-mediated age-related diseases. But we can target it with antibodies against PD-L1, which can enhance immune system to come and kill, remove senescent cells in vivo and simply ameliorate inflammation. And this potentially opens, whole strategy of designing anti-aging drugs that can be based on immunotherapy. Thank you.
Thank you, Yulia. And the next contestant, the final contestant in the fundamental track is Ekaterina Rudnitsky from Professor Vadim Freifeld's lab in Ben-Gurion University in Beersheba. And she will present on the impact of MSC-derived extracellular vesicles on the crosstalk between senescent and stem cells. And the collaborators include Ekaterina Rudnitsky, Gadi Turjiman, Vera Garbunova, Marina Wolfson, Hachik Muradyan, and Vadim Freifeld. Welcome.
Okay, first of all, I want to thank organizers for awarding our works and for this opportunity to present our results. At this conference, we heard a lot about cellular senescence and predominantly about a negative side of senescent cells. They, however, play a dual role in biological systems. Indeed, in recent years, cellular senescence was suggested to be an important or even obligatory phenomenon in cell reprogramming. But what's about natural stem cells? Indeed, in our lab, we found that the number of stem cells in fibroblast cultures depends on the stage of cellular senescence. All this points towards a possible crosstalk between senescent and stem cells. Among different ways of cell-cell communication, the important role belongs to extracellular vesicles. Our recent analysis clearly showed that mesenchymal stem cell-derived extracellular vesicles can mitigate the cellular senescence phenotype. And here, in this work, we report for the first time that impact of mesenchymal stem cell-derived extracellular vesicles on the pool of stem cells in senescent cultures. For this purpose, we collected extracellular vesicles from naive mesenchymal stem cells as well as anti-inflammatory polarized mesenchymal stem cells. And we supplemented them to incubation medium of human fibroblast cultures at various stages of cellular senescence. On the whole, we found that mesenchymal stem cell-derived extracellular vesicles attenuate cellular senescence. That is, reduce the percentage of SA beta-gal positive cells as well as multinucleated cells in culture, increased cell growth, and accelerated in vitro wound healing. As to stem cells, only extracellular vesicles from naive mesenchymal stem cells displayed a clear effect. As you can see in the graphs, these cells increased the number of stem cells in presenescent as well as senescent cell cultures. This elevation coincides well with the exosome-induced increase with exosome-induced increase in senescent cells in presenescent fibroblast cultures, which we can see here. But the problem is here, like we see the decrease of senescent cell in the culture with the same time increase of these stem cells. At the moment, we don't know how to explain this discordancy in exosome effects. However, maybe it may be the matter of nonlinear relationship between cellular senescence and stemness. Whatever, this observation led us to the suggestion that mesenchymal stem cell-derived extracellular vesicles affect not only the pools of senescent and stem cells, but presumably also crosstalk between them. Thank you very much for your attention.
Thank you very much, Ekaterina. And these were all the contestants in the Fundamental Biology of Aging and Longevity track. And the winner of the first prize is Yulia Maevskaya. Welcome. Thank you. And the two winners of the second prize is Noah Rahmian. Thank you. And Ekaterina Rudnitsky. right. So we go to the final category, which is social gerontology. The first contestant is Sanjuti Roy, supervised by Liat Ayalon from here, from Bardsley University. And the topic is ageism as a barrier to health longevity. Is Sanjuti here? Not here? Here? Do you want to present? No. That's fine. Once again, it's all about science, not presentations. And the second contestant is Peter Soon, also from the group of Liat Ayalon in Bardsley University. And his topic is advancing longevity via activity engagement, multi-channel sequence analysis. Do you want to present? No? Once again, this makes us life easier and closer to the finish. So the winner of the first prize is Peter Soon. But you're also co-author with Sanjuti, so that's fine. And the second prize is accordingly goes to Sanjuti Roy. Thank you very much to all the contestants of this first round of Longevity Aspiration Prize. Thanks to Larissa, thanks to the founders of the Joseph Gitters Foundation. In his memory, that will be hopefully a combination of several foundations, several support sources. The entire support, we don't divide the entire support for the Longevity Nation conference goes through Vatican Association in cooperation with Bardsley University, Department of Science, Technology, Society. The main sources of funding included also the Segol Network, American Federation for Aging Research, Shlomo Tyron Foundation, Deep Knowledge Group, Quadrascope, several other funders and supporters. We're grateful for all of them that even in this difficult time, they support this critical area of human development and of social and human endeavor. So we still have a formality. You know, we usually conferences adopt some kind of resolution. Generally, the entire purpose of this conference was to promote longevity field, health longevity field in Israel. Research, development, and education to raise this topic to the public awareness and academic awareness, to bring the attention of decision makers, supporters, funders, you know, to kind of increase the interconnectivity in the field, the matchmaking. So all this allows us to adopt some sort of a resolution, once again with the purpose to promote the field further. And the resolution can be the same as the last year Longevity Nation resolution. Basically, it repeats the main paragraphs, the main points of the section called Enhancing Research, Development, and Education for Health and Longevity and Prevention of Age-Related Diseases, which was actually adopted in 2019 by Knesset as part of the Israel National Master Plan on Aging report. It was published. Not many people remember it, but it's there. It's on paper. So, but we remember it. We also remember it in our conference. That's the name of this conference, Enhanced Research, Development, and Education for Health and Longevity. The main points include increasing funding, R&D budget for health and longevity research, obviously, the main necessary condition for this field to go forward. Establishing, improving a public health system for early detection, meaning basically developing metrics that we also discussed here a lot, metrics for health and longevity, as predictors of aging trajectory, predictors of aging health, as well as to evaluate the effectiveness of anti-aging lifespan and health span improving treatments, and also education, you know, teaching about the field of biology of aging in relation to other areas, because obviously the field is very multidisciplinary. Basically, every area of human endeavors can be somehow related to aging. Aging is life, but at a later age. So everything is related to aging. So basically, these are the 3 points of this program adopted by Knesset that we want to remind, and these are also the 3 points of our resolution. They were adopted in the last year. This year also said that to all the speakers there were no objections, so we can say that this program is adopted as well. Unless anybody has objections, please talk with me. Once again, we must say thank you very much to all the participants, all the supporters, all the amazing lectures, the real cutting edge of longevity research, not just in Israel, but around the world. And we hope that Israel will take its rightful leading place among the leading nations, so in the longevity field, research, development, education, as well as enhancing cooperation with the whole world. And hopefully the situation will improve also security-wise, and we'll be able to do more of this in the next year. Thank you very much again. So basically, unless somebody wants to raise some burning issue, no? Then we can have our lunch. Thank you.